All right, it is 3 past the hour, wherever you are, and I will start making a slow start, talking very slowly for another minute or so to give more people a chance to join. Thank you so much for joining us this morning. I'm Vincent Atchity. I'm the CEO of Mental Health Colorado and director of the Equitas project, which is our national initiative to disentangle mental health and criminal justice. I had formerly been the director of Equitas project and then moved over to Mental Health Colorado, and then the Equitas project followed me. So I'm not so easily disentangled from this disentangling of mental health and criminal justice, and happy to still be doing this work. Very excited for this, our first virtual national prosecutors summit. You are all such an important group of folks in our national landscape, and it's a real pleasure to have this opportunity to work with you today. We have had a series of these types of summits focused on different communities and also different operative sectors at the intersection of mental health and criminal justice. A few years ago, we hosted a national public defender summit, and we have convened experts in mental health law and policy, as well as community members in several states and municipalities and regions. And out of each of those convenings or summits, our goal as an advocacy organization to help move along this disentanglement was to produce a document. We called them the course corrections documents. And what those documents do is reflect the recommendations made by the gathered folks. And then we've used those to just try and help other communities learn about approaches to diversion and redirection. And I put a link to some of those documents in the chat. You can have a look when you have a chance. We're particularly excited to work with the prosecutors, and it really keeps uppermost in mind one of the things that I've been trying to reiterate, and every chance I get to make a presentation, is health and safety, the relationship between health and safety. You know, I come from a public health background, and you all work in a public safety world. And my view of it is that health and safety, though we have two different words for them, are not really two different things. Health and safety are one thing, and we operate at different facets of that intersection, but it's really one thing. And the more of us in our communities who understand that health and safety are tied together, and when we're strong in one, we're stronger in the other, the better off we're all going to be. And so really appreciative of your understanding of that and your work at this intersection, and very much looking forward to learning more about it. A couple of other things. So many of you have been participating in our Prosecution Research Network, which is a group of folks we started bringing together about 2.5 years ago. We got some questions after sending out the invitation to this summit about the attached document, which was the 2021 framework for prosecution-led diversion. And just to clarify, that's a document that we produced this year out of a meeting that we held with our Prosecution Research Network last year. And just, it's intended to be an overview and a sort of baseline set of directives for offices that are not yet practicing diversion and interested in exploring more of that. And the participants in creating that work are all listed on there. Our hope is to create a network, a mutually informative network of prosecutors who can reach out to one another for companionship and guidance in doing this work. I want to acknowledge our partners in the Prosecution Research Network, Dr. Carrie Pettis Davis and her team at the Institute for Justice Research and Development. They've been great to work with, and we look forward to more with them. I also just mentioned that one of the things that we're in the midst of doing is, tied to the national launch of the new 988 number next July. We're doing a public campaign called Care Not Cuffs, which is really rallying communities to be prepared for what may happen when that 988 number goes live and people are calling for health care and expecting to get a health care response, so that communities are better prepared to provide those kinds of positive crisis interventions that lead to engagement with a healthcare system, and not just a broadened pathway to criminal justice involvement. So please keep an eye out for things about Care Not Cuffs. We're interested in putting a spotlight on the local heroes, such as all of you, who are recognizing when someone is more appropriately diverted toward healthcare. That's what we're after. So some of the things that we'll cover today based on input from our prosecutors partnerships, and I'll just list a quick list of topics, and our various presenters will touch on these in one way or another over the course of our time together. We'll be talking about developing public support for diversion. I'll say a few words about that at the end. Decision-making processes for diversion, violent offense diversion, partnerships with other government agencies, what worked and didn't work during this pandemic experience, tools offices are using for their restorative justice practices, plea agreements, length of mandates, DUI diversion, pre-charge versus no charge, felony mental health court, misdemeanor marijuana plea charges, and prosecutor burnout and self-care. We have a special presentation later in the day about stress and resiliency and secondary trauma training. Looking forward to all of that. We'll aim out of today's meeting again to produce some kind of a summary document that reflects our takeaways from what all of you share today. And we will circulate that out to all of the participants for input and feedback before we finalize anything, and really look forward to producing something that's of value and supports greater dissemination of this work. Just a few more things. I want to make sure I thank our staff, Emma Troughton and Adam Goss, for all the support in getting things ready for today and all your technical support. We'll monitor the chat and they'll help me out with that. Our goal is to have as much conversation as possible. We'll have the formal presentations and then time for questions, answers, and discussions so that you feel like you're engaging with each other, and we'll just facilitate that and stay out of the way as much as possible. I want to thank the sponsors of the Equitas project and Care Not Cuffs, the David and Laura Mirage Foundation. We've also gotten some support from the NFL Draft-a-thon, who've been interested in supporting people's access to mental health care supports and services, especially in the wake of the pandemic. I also just want to mention that we are an entirely nonprofit, nonpartisan organization. We depend on giving to be able to do the advocacy that we do, both here in Colorado and nationally. And if you're able to support us with any kind of a donation, we'd much appreciate that. We'll put a link to that in our chat as well. And with that, I think I'm on time and ready. Let me just mention that the lineup today, I really also just want to warm welcome to Michelle Onken and Tony Martirosian and Douglas Halbert and his colleague Laura Reimer and Amberly Prithodko and Julie Turnbull and Judge Blanco, Chief Brandt, DA McCann, for being our presenters and panelists today, and to all of you for joining us. It was a packed schedule. We could have had any configuration of folks and really just wanted you all to meet one another and have a chance to talk. So thank you for being here. So with that, I will now introduce our keynote speaker, my friend, Judge Steve Leifman. And a few words about Judge Leifman. Judge Leifman is an associate administrative judge for the 11th Judicial Circuit Court of Florida. He served as special advisor on criminal justice and mental health for the Supreme Court of Florida since 2007. And he's known nationally for his efforts to keep mentally ill individuals out of prisons and jails. Judge Leifman was chair of the court's mental health subcommittee for 3 years, and he started the 11th Judicial Circuit Criminal Mental Health Project, which has diverted mentally ill people who would otherwise have ended up in the criminal justice system into care and treatment since 2000. Judge Leifman has received the Brain and Behavior Research Foundation's Productive Lives Award, and he became the first Floridian judge to have received the William H. Rehnquist Award for Judicial Excellence from Chief Justice of the United States, John Roberts. Judge Leifman is also a member of the board of the American Psychiatric Foundation, and we're very happy to have you with us this morning. Steve, thank you so much.
Sure. Thank you, Vincent. And it's really a pleasure to see everybody. And Vincent, thank you for the thoughtful introduction, but more importantly, for the remarkable work that you're doing, not just in Colorado, but around the country. It is incredibly appreciative. I also want to thank all the prosecutors that are with us today. Vincent touched upon it, but in many ways, you may be the most critical component of the work that we are trying to do, because without the support of the prosecutors, without the understanding of the prosecutors, it's very difficult to do what we're trying to do. So I thank you. And I'm going to divert a little bit from my own presentation, just to kind of follow up a little bit on what Vincent said, because I want to make it really clear on the population that we're dealing with. And first and foremost, this always is about public safety. And right now, I don't think people understand this population well. Generally, people with serious mental illnesses are no more dangerous than the general population, although that number goes up slightly when they are under the influence of drugs. However, on medication, people with serious mental illnesses are actually much, much less dangerous than the general population. Sadly, they are much more likely to be victims of violent crimes than perpetrators of violent crimes by a very, very wide margin. The key to me is just making sure that we get treatment. Most of the charges that people with these serious illnesses come in on are relatively low level. And the people that we're working on to divert are not the people that are charged with heinous offenses. And so we know that 90-something% of this population that do get arrested with a serious mental illness get released relatively quickly. And so we really have two choices. We can release people with treatment, or we can release people without treatment. And we know that there is a significant difference in improving public safety when we release people with treatment. And it also enables them to get into recovery and have a life of hope and opportunity. And it saves a lot of taxpayer dollars, because the way we're doing things right now that we're going to talk about in a few minutes, it's pretty foolhardy and pretty dangerous. I will tell you, I've been on the job, I've been on the bench now for about 23, 24 years. And what you really learn after several years on the bench, particularly in the criminal division, is that the criminal justice system in many ways is the repository for many failed public policies. And there is really no greater failed public policy to me in the criminal justice system than our treatment towards people with serious mental illnesses. I've been involved in this issue for many, many years. Actually, my first exposure to this issue was when I was 17 years old. I was an intern for a state legislator, a state senator in Miami, and he received a letter from the then editor of the Miami Herald about a young man who was at our local state hospital. And the letter was pretty tough, and it talked about terrible mistreatment of this young man. And they wanted to know, since this was a state facility, if the state senator could do something about it. Now, my age directly corresponds to the deinstitutionalization movement. So 45 years ago, this was right out of One Flew Over the Cuckoo's Nest. I grew up in a nice, middle-class family. I never saw anything bad or terrible. And I was assigned to go to the state hospital by the state senator to check out this young man. And it was a horror show. It was pretty repulsive. It was pretty horrifying. And I went in and I found the young man, and he was in all 4-point restraints. He was probably 100, 150 pounds overweight from the Thorazine that they were injecting him with, because that was the only real medication they had 45 years ago. And he was moaning and screaming, and it was just a horrible, horrible scene. This was also way before HIPAA, so I started to look at his files and I talked to the staff, and I was pretty shocked, because even as a 17-year-old who had no real power or very little information, I knew one thing, and that was I found out that he was autistic. He was not even psychotic, and that clearly was not the place for him to be. And this is part of the reason we ended up shutting down these hospitals, because of these terrible treatments that were going on. Anyway, while I was there, it turned out that there was a group of advocates at the facility, and they heard there was someone from a state senator's office, albeit again, a 17-year-old with no power and very little information, but they insisted that I go on a tour of this facility. And they took me downstairs to what looked like a dungeon or a jail. I remember vividly like it was yesterday. And when I got down there, I found these 7 men lying naked in their own feces, while a guard stood there with a hose washing them down like they were animals in a zoo. And it was traumatizing. And I just couldn't believe that we treated human beings this way. We treated animals better than we were treating these people. Now, the good news is we got the young man out of the hospital, and he ended up living, the best quality of life he possibly could. It actually, he ended up in a really good place. But about 17 years later, I was appointed to the bench, and these same horrors that I had witnessed in this facility, I was now witnessing in my jail directly across the street. And what I basically learned is that when I became a judge, I was becoming the gatekeeper to the largest psychiatric facility in the state of Florida, and that was the Miami-Dade County Jail. And so while the United States has about 4% of the world's population, amazingly enough, we have 25% of the world's inmates. So 1 out of every 4 inmates in the world is housed in the United States. 70% of all people today in jails and prisons in the United States either have a serious mental illness, a substance use disorder, or both. In some ways, I've started to think that maybe what we really should be doing is having specialty courts for the 30% and using the rest of the criminal justice system as a therapeutic jurisprudence model, and making sure that people get the treatments they need, because frankly, our system doesn't work. We spend almost $1 trillion a year in the United States on direct and indirect costs related to criminal justice involvement. Prior to the pandemic, 1 out of every 115 adult in the United States was behind bars, and 1 out of every 38 adult in the United States was under correctional supervision. Since 1980, the number of people going to jail and prisons in the United States has increased by more than 500%, and sentences have increased by more than 166%. Many, if not most, of these increases are truly due to untreated mental illnesses and substance use disorder. In fact, people with mental illnesses in the United States are 10 times more likely to be incarcerated than hospitalized. They are 19 times more likely to find a bed in the criminal justice system than at any state civil hospital. Annually, we have about 1.5 million people with serious mental illnesses arrested in about 2 million incidents, because there's a lot of recidivism, so they get arrested on repeated offenses. And on any given day, we have about 380,000 people with serious mental illnesses behind bars, and another 574,000 people with serious mental illnesses under correctional supervision. In a survey of about 1,400 families from the National Alliance on Mental Illness, they found that 40% of every family member had a loved one who had been arrested at least 1 or more times. And so aside from the enormous human cost of using our criminal justice system as the de facto mental health system, the fiscal impact to government and taxpayers is also astronomical, and it provides very few, if any, measurable positive outcomes. Miami-Dade County, for instance, spends $636,000 a day. That's $232 million a year to warehouse 2,400 people with serious mental illnesses each year. Comparatively, the state of Florida spends about $47.3 million to provide services for 34,000 people, leaving about 70,000 people without any access to care. So let's put this another way. We spend about $100,000 per person to lock them up in jail who have a serious mental illness. And remember, most of them get released at some point that year. Versus about $1,400 a year per person to maintain people in recovery in the community. Annually, our counties collectively spend about $26 billion on jails each year, and our states spend another $63.5 billion on direct prison costs, and the states spend billions and billions more each year to restore competency for a very small group of individuals, which I will come back to that in a few minutes. You know, the situation is particularly shameful because treatment works. Recovery rates for many people with serious mental illnesses is actually better than for people with heart disease and diabetes. We have a system problem more than we have a treatment problem. Most of the money we spend in this country related to mental illnesses is wasted on acute care treatment provided in institutional settings, whether it's a jail, a hospital, or a competency restoration facility or prison. In fact, most states spend more money to incarcerate people with mental illnesses than to treat them. And as Miami-Dade County, the Miami-Dade County example suggests, clearly our system is backwards. And then one thing that we rarely talk about that we really should talk a lot more about is what we call the comorbidity issues of this population. This relates to their primary healthcare issues on top of their serious mental illnesses. We know, for instance, that people with serious mental illnesses have higher rates of heart disease and cancer than people without serious mental illnesses. They are also more likely to be admitted to a hospital, and they are also more likely not to have insurance. Additionally, in a study that was just published in Denmark about a month ago, they found that there's also a large earning penalty for people with untreated mental illnesses. This was really interesting. So that if you have depression, for instance, you're going to make 34% less in the marketplace. If you have bipolar disorder, you're going to make 38% less. And if you have schizophrenia, you're going to make 74% less in the marketplace. Now, if you're treated, that number goes, those percentages go way down and earnings go way back up. And so we are causing this terrible situation where we force this population also almost into poverty, and we force them in many ways to continue to cycle through these very bad and acute systems of care that do nothing to improve the situation or improve our public safety. The paradox is that the pandemic really affords us an opportunity to finally address this crisis. As our jail populations have been significantly reduced due to COVID-19 and arrests are at an all-time low, we really should take this opportunity to re-envision and restructure the delivery of mental health services in this country. You know what? Because we know what works. What we have lacked is the political will to make a change and the opportune time to act. In this pandemic, if there's anything good about this terrible pandemic, gives us that once in a lifetime chance to make a change. And it is fixable. There is substantial evidence based on well-researched data and proven strategies on how to fix this problem. And you don't necessarily have to start by overhauling the entire system. And, you know, people are so quick to get overwhelmed. Oh, we can't fix the whole system. You're right. You don't need to start by fixing the whole system. If you just start by targeting the people that are the highest utilizers of criminal justice and mental health services, you can shift millions and millions of dollars back and towards and back into the front end of the system to help people from ever ending up in this system alone. And I will give you the classic example. At the University of South Florida, they have something called the Florida Mental Health Institute. And they're one of the only institutions in the United States that I'm aware of that have these blended data sets that can actually tell a community who the highest utilizers of both criminal justice and mental health services are. So they have access to all of our civil commitments. They have access to all of our arrests in Florida, all of our Medicaid and Medicare records. And so they literally can tell you by name all the people in your community that are cycling through these systems the most. So we sent them, when we were really picking up steam on our program that I'll talk to you about in a minute, we wanted to see who we should be wrapping our arms around. We knew we couldn't or didn't need to help everybody, but there was a core group that was killing the whole system. So we sent them the names of 3,300 people who had come through our system over a 5-year period that had been identified as having a serious mental illness and qualified for our diversion program. So we sent them this data, and I waited, and they sent me a letter back, and I opened this letter, and there's one piece of paper in this envelope. And on this piece of paper were the names of 97 people, primarily men, primarily diagnosed with a schizoaffective or schizophrenia disorder, primarily homeless, and primarily co-occurring, meaning they had both a serious mental illness and a substance use disorder. These 97 people over 5 years were arrested 2,200 times. They spent 27,000 days in the Dade County Jail. They spent 13,000 days at a state-funded psychiatric facility. They cost taxpayers $14.7 million, and we got absolutely nothing for it. And I guarantee everybody that is on this Zoom meeting today has their 97 in their community that are cycling through every acute system of care in every one of your offices on a regular basis. And many of us know them by first name. Just this past March, because we have expanded so many of our programs, and we actually have an assisted outpatient treatment program in our criminal court that I'll also talk to you about. We identified 15 people just this past March who qualified for the program. These 15 people in just 1 month had been arrested 331 times. They had spent 9,120 days in our jail, of which over 2,000 of those days were in a psychiatric unit. And they cost our taxpayers almost $2.5 million just for jail costs for these 15 people. So my journey into the criminal justice mental health world actually began one morning when I was getting ready to go on the bench. I was approached by the assistant public defender and the assistant state attorney, and they came and told me this story and asked me if I would speak to a couple whose son was in jail on a case I was about to hear. This was at the beginning of my career, and at the time I was handling what we call, you probably have it, a misdemeanor jail division. So 3 kinds of people you find in the misdemeanor jail division. So these are people in custody on a misdemeanor. They either are still in custody because they have an attached felony and they're not allowed out of custody. They're too poor and they cannot afford a bond out of custody, but mostly it was just people with serious mental illnesses that didn't know how to get out of custody. So this lovely couple came into my chambers. They were very sophisticated. They seemed to be very well off, and they were terribly distraught. The mom was crying, the dad was shaking, and they literally began to beg me to get their son help. They told me that their son was brilliant. He had a late onset of schizophrenia. He had gone to Harvard, and he was now homeless and cycling through on a regular basis, and they just didn't know what to do. And I think when you're a newer judge, you think you have a lot more power and a lot more wisdom than you do. And I was under the assumption that if you got arrested and had a mental illness, there must be a mental health system to put you into, because unfortunately in Florida at that time, no longer today, we have very serious training, but at the time there was absolutely no training on how to identify or what to do with people with mental illnesses. So I made one of those rookie mistakes, and I promised them that I would get their son help. And so as I started to go back into the courtroom, the mom stopped me and she said, "Judge, there's one more thing I need to tell you about my son." She said, "Not only is he brilliant, but respectfully, he probably knows more about the mental health system than you do." And I wasn't clear what she was trying to say to me. And I said, "Excuse me?" And she said, "Oh, you see, my son is the former head of psychiatry at Jackson Memorial Hospital, the largest public hospital in the state of Florida." I was pretty taken back. I went in, I called his case. We started to have an amazing conversation. He was coherent, he was thoughtful, he was more respectful than the lawyers. And I'm thinking, hey, maybe there's something wrong with his parents. He seems totally fine, except when you looked at him, he looked like a homeless guy that hadn't bathed in months. But we started to have this really thoughtful conversation, and he insisted that there was absolutely nothing wrong with him, and that if I would just release him, he would go get evaluated, he would come back. And in his words, he said, look, Judge, I didn't do this offense, but even if I did, I wouldn't be in jail over it, because I don't remember specifically because I didn't keep any of his paperwork. I had no idea his case was going to change my life. But I think he was in on a non-statutory offense, a local county ordinance like possession of a dairy cart, which a lot of homeless people get picked up on because they commit quality of life offenses. And what I have also found is a lot of times the police were under the same misinformation that I was, thinking that if somebody got arrested with a serious mental illness, they would get treatment because nothing else seemed to work out in the community. Well, sadly, nothing could be further from the truth. Anyway, I started asking him a series of questions, and I said to him, hey, I don't understand. If you keep saying there's nothing wrong with you, you don't have any kind of mental health disorder, but if that's the case, why would a Harvard educated psychiatrist be in jail and recycling through our system? Well, because I was untrained, because I didn't know what I was doing, I never should have asked that question, because I caused him to have a full-blown psychotic episode. He started shaking back and forth, and he started screaming at the top of his lungs, and he started pointing to where his parents were sitting, and he started yelling that his real parents had died. Everything was in sixes. They had died in the Holocaust, and the people in the courtroom were from the CIA, and they'd come to kill him. And the only thing I had been taught from the judge whose division I took over is that if someone acts strange or bizarre, order a psychological evaluation. I didn't even know what I was supposed to do with it. So, of course, those things don't take a day. And at the time, we needed 3 to get the lawyers to stipulate. And he ended up spending almost 10 to 12 weeks in jail on possession of a dairy cart so I could get him fully evaluated. All 3 evaluations came back, and they said he was not only incompetent to proceed, but he even met Florida's very difficult standard for civil commitment because he was imminently dangerous to himself or others. And I'm thinking, this is great. I'm going to be a hero. I'm going to fulfill the promise I made to his parents. We're going to live happily ever after, and I'm never going to have to deal with this type of issue again. Well, that was 21 years ago, so you can imagine what ends up happening. I have him adjudicated incompetent. I begin to order him into some kind of forensic commitment so he could be restored, only to have the assistant public defender hand me a case that had come out 1 month earlier that said the county judges, of which I am, have 0 legal authority or jurisdiction to to forensically commit anybody or civilly commit anybody for that matter. And that my only option was to release him back to the street. Floridly psychotic. And as much as I hated it, we all know that we have to follow the law. And not only was I unable to fulfill the promise I made to his parents, but I put him at risk. I put the community at risk. I probably put myself at risk. God forbid something terrible happened to him or something he may have done to someone else. And I was determined that we would never be in that situation again. So I'm going to stop real quick, and I want to show you a short video that was produced by my local CBS 4 affiliate. We had a very serious crisis in Florida pertaining to competency restoration. We ran out of beds. Florida is unique in a good way that we require our State Department of Children and Families to physically move someone from jail within 15 days of an adjudication of incompetency to the state facility for restoration. Well, the state had ignored it because they ran out of beds, and it created this terrible backlog in our jails around the state. So Vincent or Emma, if you could please roll, or Adam, hi Adam, if you could roll the video, thank you. I don't hear any volume. Can we stop? There's no volume. Give it another shot.
Are you getting anything?
Try again.
People who spend their days and nights in
Yes,
these jail cells all suffer from mental illness. They're accused criminals, not guilty in the eyes of the law, but forced to live in conditions you cannot imagine.
Are Our chief investigative reporter, Michelle Gillen, has been given unprecedented television access to reveal what's going on. Michelle joins us now, and I was shocked, to say the least, when I saw this.
I think certainly it is time for the public to see what is going on. The pictures you are about to see are indeed haunting and most disturbing. Hundreds of men with mental illnesses, many crammed into tiny cells. Some arrested for minor crimes that advocates say would have the average person out of jail in just hours. But incredibly, there is no place to send them. Tonight, our cameras take you inside a world rarely exposed. Is sealed cell. Some beg for help. The barest of necessities. Water. The faucets are dry. Working it doesn't work. The faucet. These cells were designed for one person. With only a single steel shelf for a bed.
In this one, there's 3 inmates in a cell for one.
Yet 2, 3, sometimes even 5 minutes. Diagnosed with mental illnesses in most cases arrested for low-level felony crimes. In some cases, misdemeanors are locked up for days, weeks, months. Tell me about you. Tell me, living in this, what do you want the public to know tonight?
I want the public to know that people on the floor, and you have to sleep on top of it. There's only one bunk that's made of steel. There is 4 in here right now.
They are only allowed out of the cell for 15 minutes, 2 times a week.
30 minutes a week are allowed out.
So other than a half an hour,
That's it.
this is it. In this room,
Lights are on 24/7. The conditions you see just do not change.
jail's chief psychiatrist, Dr. Joseph Mortier.
You would think that in 2006,
chronic mental illness in a much better, more humane manner. But unfortunately, we're reverting back to how it was in the 16 and 1700s, which is terrible. It's morally incomprehensible.
A sentiment echoed by an outraged Miami-Dade County judge, Steve Leifman.
This is like a secret that people don't know
It's a
about.
bad secret, and it's a sad secret.
What most of you don't know is that the Miami-Dade jail now serves as the largest psychiatric facility in the state of Florida. 3 of 9 floors burgeoning with inmates suffering from mental illnesses and, according to Leifman, in desperate need of treatment. Not this type of confinement designed to punish people.
5 times as many people in our jail with mental illness than any psychiatric hospital in Florida. 5 times.
In this right here.
Right here.
An elderly man emerges from the dirt and darkness.
There's one on the floor underneath the bunk and 1 or 2 standing around waiting for their turn to sleep.
And the crisis has unfolded across the state. In other Florida jails where they strive to comply with all the national standards for housing inmates, frustration over the virtual abandonment of mentally ill inmates left by the state to languish in jail cells for months runs deep. Colonel David Parrish.
Can you imagine the chaos that would result in the local criminal justice system if I stood at the booking door and said, sorry, we don't have any more room, we're not taking them from you, law enforcement?
Parrish from Hillsborough County says local authorities had no choice but to sue the state of Florida to force the Department of Children and Families to comply with their legal mandate to transfer mentally ill inmates to a treatment facility within 15 days.
Jails should not be the de facto mental health facility for a county, but that's what they are in the United States.
You had your birthday here. How old were you?
I was 21
21, and you've been here 8 months. In Pinellas County, the weight of incarcerating and caring for mentally ill inmates had everyone paying a price, an unacceptable one, according to Major Kirk Brunner.
We are not a treatment facility, and these people that you saw in Delta 1, the one that plucked his eye out, they need to be in a treatment facility, which is the responsibility of the state, not our responsibility.
And therein lies the danger. William Weaver Sr. was caring for his 40-year-old son Bill at home, a son he says suffered from schizophrenia but functioned well for decades until his medicine was changed. Then one night, according to police records, he attacked his elderly father, who called police and urged them to arrest his son, hoping this would trigger treatment.
Because he was under the false idea that if he got arrested, he'd get treatment.
Bill ended up locked up in a cell on floor 9 of the Miami-Dade Pretrial Detention Center for several months. According to authorities, Bill jumped from this top bunk bed, cracking his skull and breaking his neck. He's now a quadriplegic who needs hospitalization to stay alive. We met up with his father, who had just left his hospital bed.
Do you think anything has come from what the incident of what your son went through?
Nothing. Nothing's changed. Do I think something could change? I don't know. I don't know. It's time. It's time. Something changed. But I don't know if it ever will.
It's a pretty tragic look at the state of our mental health system, not just here in Miami-Dade, but around the country. Tragically, the young man who was injured died as a result of his injuries a few years ago. And we believe his father may have passed soon thereafter, probably from a broken heart. Things do change. We closed down that horrible 9th floor, and we opened up a much better facility in the jail for people with mental illness. But the answer is not building better jails, more humane jails for people with mental illnesses. The answer is keeping people with mental illnesses out of the criminal justice system, or redirecting or diverting them once they do penetrate our system. You know, I've been doing this for over 20 years now, and I've come to a very simple conclusion, that if we treated people with primary health issues the way we treated people with mental illnesses, not only would there be civil lawsuits, but there would probably be indictments for gross negligence. You know, I took my dog to the vet a few weeks ago on a Saturday. Of course, they were open on Saturday, and he was fine. It was no big deal. And Monday morning, the phone rang like at 8:30 in the morning from the vet wanting to know how my dog was. We don't even do that as a follow-up to people that go to a crisis center. You know, I don't have a lot of time. I could spend probably an hour just on the history of mental illness, but I think it's important to note, particularly if you're a newer prosecutor, this isn't the way it always was. We didn't always lock people up. Well, we did, but in a really bad, weird way. And you know, when the country was first founded, we didn't know what to do with people with mental illnesses in the United States, so they would just put them in jail, even if they had not committed any offenses. And so the English had a pretty civilized system of care for people starting in the 13th century with both intellectual disabilities and serious mental illnesses. But when the US was created, you know, the colonies were formed, there was no infrastructure. And so they were unable to transfer that system of care that they developed in England to the United States. So instead what they did is they just took people that acted to them strange or bizarre, and they put them in jail even if they didn't commit a crime. And it stayed that way until about 1840, when this wonderful woman by the name of Dorothea Dix was visiting a jail in Boston in the dead of winter, and she came across these 14 men who were segregated from the rest of the population. They had very little clothes, no blankets, no heat, and they were freezing to death, literally freezing to death. So she went to see the jailer, and she's like, "Excuse me, who are these men, and why are you allowing them to freeze to death. And the jailer is like, look, lady, they're just a bunch of lunatics. That's how they referred to them back then. They haven't committed any crimes, ironically, he says to her. So I'm not getting paid to keep them. What do you want me to do? Well, this one woman was so horrified by what she saw. She adopted a movement that had begun in France called moral treatment. And the idea was to morally treat people with these illnesses and to move them from jail and into asylums. And the idea was to take people that were just sick, who hadn't committed crimes, and put them in these small 120-bed facilities, asylums. And people started to get better because the stress and the trauma and re-traumatization of being in jail made people a lot worse. And so she went to the Massachusetts legislature. They created the first law for asylums, and they started to move this population. And as I said, some people actually got better just by putting them in a better environment. Well, you know, our states, they can't help themselves, and they're not going to spend a lot of money on 120 people. So they start to consolidate these asylums, and they grow them into these massive state hospitals, like the one I saw when I was 17. And they had thousands and thousands, some of them tens of thousands of patients. And they had no oversights and no regulations. And they really became these human experimentation facilities. So the first treatment for people with serious mental illnesses was insulin shock therapy. They did some rudimentary tests. They found that some of these folks had slightly elevated blood sugar levels, and these doctors are like, aha, it's diabetes causing their insanity. So they went around and they gave everybody an overdose of insulin. And of course, that didn't work. People got sick and they checked it off the list, but they're like, hey, maybe we're onto something. We could shock people back into sanity. So they invented something called the electric shock therapy. They tied you to a table. They put a stick in your mouth so you didn't bite off your tongue. They put electrodes on your head, and they'd shock the living hell out of you with the hope that they would shock you back to sanity. And of course, that didn't work. And when all failed, some guy who, I don't know why he thought he was a doctor, was apparently a doctor, developed something called the Friedman pick. And they would take you into that same room and tie you to the same table. And they would take a pick and they would punch it behind your eye, and they would do a lobotomy on you. And believe it or not, this was the general practice until the late 1970s. Some of us were alive at this point. This isn't 100 years ago, you know, when we didn't know better. Well, in 1950, the first medication, Thorazine, was developed. It was oversold as a cure, which it was not. And in his last public bill signing in 1963, President Kennedy signed a $3 billion authorizing act that created this wonderful national community mental health system. One of the reasons he did it is his sister, Rose, had serious mental health issues. They lobotomized her. It was done terribly poorly. She was basically tortured and spent the rest of her life in really poor condition as a result of this botched lobotomy. Well, so he passes this act, and tragically, due to the president's assassination and the escalation of the Vietnam War, not one penny of the $3 billion ever got appropriated. But at the same time, because of these terrible conditions that I just described, a slew of lawsuits got filed all over the United States against the states for these terrible conditions. And the main seminal case actually comes out of Alabama. And it's an amazing case. And I don't, again, have a lot of time to get into the details, but I would really commend you to watch it. Look at it. And it's called Wyatt v. Stuckney. And what makes it so remarkable is the federal judge that got the case, Judge Johnson, amazing, remarkable judge, same judge that freed Martin Luther King out of an Alabama jail. Really thoughtful. There's a whole series of PBS interviews with him, and they're really worth seeing. So what Judge Johnson does, they file this lawsuit, and what he ends up finding is that, hey, if you're in jail, we already knew that you had a constitutional right for adequate treatment. That right had not existed if you were in a state civil hospital. And so basically what Judge Johnson does is he expands that right to a state civil hospital. And he basically gives Alabama two choices. They could spend hundreds of millions of dollars improving their facility, or they could shut it down. And Alabama actually started to make a lot of changes, but they ran out of money. And Judge Johnson had told them, if you don't make all the 48 changes that I'm requiring, I'm going to shut you down, or 84, I think it was 84 actually. And so the case starts to percolate up to the Supreme Court, and basically the states have two choices. They could either spend billions of dollars upgrading their facilities so they could treat people like human beings, or they could shut them down. Well, we know what they did. They didn't spend the money. They shut down many of their hospitals, and it caused what we now refer to as the criminalization of mental illness. And so as we combine that with deinstitutionalization, along with the war on drugs, the war on crime, sentencing guidelines, and massive housing cuts in the 80s, this perfect storm was created. In 1955, there were some 560,000 state hospital beds around the country. If nothing had changed, and I'm not advocating this, I just want to put this in context. If nothing had changed, we'd have about 1.5 million state civil hospital beds if our population continued to grow the way that it has ended up growing, which ironically, it's almost the exact number of people last year who were arrested in this country with serious mental illnesses. Today, we have less than 40,000, I think it's about 32,000 state civil hospital beds left in this entire country. And in 1955, it's estimated there was only about 5,000 people with serious mental illnesses in jails. And so we have just flipped the system on its head. We went from having basically no one in jails and prisons with serious mental illnesses to now becoming the largest psychiatric warehouses in the country. Since 1955, the number of psychiatric beds in the US has decreased by more than 90%, while the number of people with mental illnesses in our jails has grown by 400%. And so there are two sad and terrible ironies. Number one is we never deinstitutionalized. What we did, frankly, is we allowed for the transfer of responsibility from these really terrible, horrible, crappy state hospitals to these really terrible, horrible, crappy jails. And in many ways, we made things more difficult because it's harder to get into recovery in jail. It's more likely that you're going to meet criminals and maybe start committing crimes. You're going to have a criminal record, and it's going to be hard to get a job or housing. And we just put you in this cycle for life. And the sadder, maybe the more cruel irony, is that we've now come full circle. We've gone almost 200 years, and we're worse off where we were than when Dorothea Dix got those 14 people out of the jail in Boston. It is the one area in civil rights in this country that we've actually lost ground on, and we have gone backwards. And we have failed miserably these individuals that need our help for recovery. And so what has happened? We've seen homelessness increase. We've seen police injuries increase. We've seen police shootings of people with mental illnesses increase. We've wasted critical tax dollars. And in many ways, we've made mental illness a crime in this country. In Florida, our police actually initiate more involuntary commitments than the total number of arrests that they make for robbery, burglary, and grand theft auto combined. And if this wasn't disturbing enough, let's talk about some of the fiscal impact on our state and local resources. Competency restoration. I know each state does it a little different. Florida does not have competency restoration for its misdemeanor population. Kudos and congratulations to California. I know Judge Blanco is going to be speaking later today. He's awesome. He's doing great work out in California. California just passed a law recently and the governor signed. No more misdemeanor competency restorations, diversion, redirection to treatment for that population. Much better way to go. So that video I showed you actually came about. I told you that we had run out of beds. And in Florida, what we found is that we actually spend 22% of our entire adult mental health budget. That's $135 million for 1,500 forensic beds for competency restoration, serving about 2,500 people a year. It's insane. And what's worse is for many of those individuals, for about 70% of those individuals, one of three things happen to them after they are so-called restored. And this is just on felonies in Florida. They either have the charges dropped because the witnesses disappear, they get credit for the time served because it takes so long to get them restored, or they get probation. And under all three scenarios, they leave our courthouse without any access to treatment, often getting rearrested sometimes before they even leave the courthouse because they are sick. Restoration is not a treatment facility. It is a restoration facility. And for most people, it is a waste of time and money. In my opinion, what we need to be doing is limiting restoration to people that are charged with really heinous offenses that need to go to prison. And we should be taking those dollars and redirecting them to treatment to keep people out of our system. And if that wasn't bad enough, and I tell people the definite, competency restoration really is the definition of insanity, where we just keep doing the same thing again and again, expecting a different outcome. And if this wasn't bad enough, just consider the impact to our prisons. In Florida, like most prisons around the United States, we have seen a relatively leveling off of prison growth, but we're not seeing that with the mental health population. And so in a period, we saw about a 50% increase in our general population. We saw a 153% increase for people needing treatment for mental illnesses. It's growing so fast in Florida that if we don't do something to curb the growth of our mental health population, Florida's going to have to build 10 new prisons over the next 10 years just to house the mental health population. And they're not committing heinous offenses. The average stay for an individual in Florida in prison is only 2.5 to 4 years based on sentencing guidelines, because they're not committing heinous offenses. And to me, there's something terribly wrong with a society that is willing to spend more money to incarcerate people who are ill than to treat them. So where do we start? It really is about a cross-system collaboration. Every system is a little different. And so 80% of the solution rests in the individual community, which makes it some ways more challenging, but also more doable. This has become such a hot issue that the Conference of Chief Justices and the Conference of State Court Administrators, only for the third time in their history, have actually created a task force on mental health to change the way that the court is handling cases, not just in its criminal system, but also in its civil justice system. And so while more and more judges are becoming involved in this issue, the reality is that none of us can fix this alone. It really takes a collaborative between the judiciary and all the non and traditional partners, such as law enforcement, prosecutors, particularly prosecutors. So thank you for being here. Public defenders, defense attorneys, corrections, your state Department of Children and Families, your local government, your providers, primary health providers, hospitals, family members, and people with lived experiences really need to come together to fix this problem. And for us, for many years, there was a recognition that our forensic mental health system was really a disaster and it really needed to be overhauled. And we began this reform in 2000 after this horrible situation with this psychiatrist that I earlier described. And fortuitously, the first national meeting was in Miami. And it's good to be judged because I went and it was an amazing meeting, and I started to beg them and was able to get their last grant of the year. And they sent us 3 amazing experts. And, I tell people, and it's half funny, but mostly true, the best thing about being a judge is that when we invite people to a meeting, they come, even if they don't want to be there. And so I invited all the traditional and non-traditional stakeholders to a 2-day summit. And we had these amazing experts come in. And the first half day, we literally mapped out the intersection between the criminal justice system and the community mental health system. And what we found is that we, the healthy, sane people, were embarrassingly dysfunctional, that we had created a system designed to fail. And we were really good at that. It failed perfectly. And the classic example was in our misdemeanors. We didn't even have restoration, but we'd order all these evaluations. The county was spending between $1 and $2 million a year evaluating people for arrest to see if they're competent, and then didn't do anything with them. And it was just a big waste. And what we found is that there was no one entity or person that was responsible for this one person who was cycling through all of our different systems every day. And so as a result of this summit, we designed and developed a 2-part approach, and it was a pre and post arrest diversion system. And if I had to do it again, I would have a 3rd part, and we could have saved probably 2 generations of people by now if we did it. And that is identifying trauma at a much earlier age, like using tools like ACEs, Adverse Childhood Experience Assessment tool in middle school for every middle school kid. And as you start to think about doing the kind of work that you're doing, and again, we appreciate it so much, think about how do we move upstream a little bit and we prevent people from coming in. So I want to stop there real quick because I want to tell you about how important trauma is. 92% of all the women in jail and prisons in the United States with serious mental illnesses have horrific histories of trauma. 75% of men in jails and prison with serious mental illnesses also have horrific histories of trauma. For the women, it's usually sexual abuse. It's usually when they are young, 6, 7, 8-year-olds, and they are victims. And then what happens is trauma is not an emotional response. It's purely physiological. You have this thing in your head called the pituitary gland as part of your warning system. And so if you are horribly traumatized, your pituitary sends a message to your adrenaline system and it releases the chemical cortisone, and it gets to your back to your brain in a nanosecond and is your flight or fight mechanism. And if you cannot escape the trauma, you continuously get overdosed with cortisol, and a young brain that's hit with cortisone is damaged even more than an adult brain, and it permanently alters brain activity. And this is what causes PTSD. It is very real. It's as real as you breaking your arm. It's a break in the brain. And so we need to be doing a lot more in trauma for the adults that we already have in our system, but also to identify it earlier when these kids are in middle school, because we know that if you have like a score of 4 and above on your ACEs, there's like 100% chance that you're going to have a substance use disorder and probably a mental health disorder. And so why are we waiting? Anyway, so what we did is we set up a pre and post arrest system. Our pre-arrest system was based on the crisis intervention team model out of Memphis. It's a 40-hour training program for law enforcement. Unlike Memphis, we don't have one department, we have 36. It has taken us many years, but we now have this amazing, sophisticated CIT program. We have the largest trained officers in the United States. We have well over 7,600 police officers at all 36 of our departments trained in CIT. We keep data on all the calls the city of Miami and Miami-Dade made over a 10-year period. And up from 2010 through 2019, those two departments alone out of our 36 departments handled 105,268 mental health calls. Yet they only made 198 arrests out of those 105,000 plus calls. What ended up happening? Well, from the time we started training to full training, our arrest after we had trained all of our officers precipitously dropped. We went from having 118,000 arrests per year to about 53,000 before COVID. And we have been able to estimate that about, as a result of CIT, we get about 3,700 fewer arrests each year since implementing CIT, which equals 109,704 fewer arrests to date, or 300 years of jail bed days saved for the county, which is a cost avoidance of over $29 million a year. In addition, our jail audit shrunk from about 7,300 to 4,000, enabling us to close one of our 3 main jails at an actual real savings of $12 million a year. It's been closed now for 7 years. That's $84 million in real savings. We also recently did an analysis with the city of Miami, and we looked at police shootings, the 5 years before CIT, the 5 years after CIT, and the last 5 years. And what we found is we went from 90 police shootings in the 5 years before CIT to 30 police shootings the following 5 years after CIT, and the last 5 years, less than a handful of shootings because we have significantly changed the dynamic. And part of it we found, and this is something none of us should ignore, that about 20% of our police officers really also suffer from severe PTSD. My mental CIT coordinator gets about 150 calls a month from our police officers for their own personal mental health issues. It explains why last year more officers died from suicide than in the line of duty. They have high suicide rates, they have high domestic violence rates, they have high substance use rates, and they have high divorce rates. And most of it is primarily due to their own PTSD or mental health issues. Remember, you have a lot of returning vets that had trauma before coming into the department, and have gotten re-traumatized, and you have officers getting traumatized on the department. And we know that the stigma is so bad, the last place they want to go is to their department for help. So we actually set up a treatment program for them outside their department with the permission of their chiefs. And it has made them incredibly empathetic and supportive of our program. You're now the cool police officer. If you get punched by somebody with a serious mental illness and you don't make an arrest, and you're a wimp if you get touched or pushed by somebody with a mental illness and you do make an arrest. We've also set up a system so that if they get spit on and they want to get an AIDS test, or in these cases today, a COVID test, we have a system in place so they don't have to make an arrest, and we have a blood test or a test drawn at a facility. We also set up a post-arrest diversion program, which has also been incredibly successful. We changed the screening tools at the jail. So now if you get arrested on a misdemeanor in Miami-Dade and you have a serious mental illness, you're identified at the time of booking. You're screened by a jail, not a jail professional, but a healthcare professional. And if there's an indication of a serious mental illness, you're segregated that day into the nice part of the jail. The psychiatrist sees you that day. And if you meet criteria for our program, meaning you meet criteria, say for an involuntary commitment, we get you out of jail within 3 days to a crisis unit. And because you're on a criminal hold, we reset the case for 2 weeks. The 72 hours doesn't apply. A member of our team goes to see you, encourage you to come into the program. Our program is voluntary. It's also pre-adjudicatory. We do not require people to take a plea for treatment. And upon successful completion, in most cases, the state null process or dismisses the charge. And when they can't, because maybe there's a victim that won't approve, they'll withhold the adjudication and will waive the court costs. Guess what happened? Our recidivism dropped like a rock. Our misdemeanor recidivism dropped from about 75% to 20%. Our prosecutor, our elected prosecutor, was so impressed by what she saw, she enabled us and allowed us to expand it. Now we do nonviolent felony cases. The recidivism rate there dropped from about 75 to 25%, saving the county 84 years of jail bed days to date. Treatment works. We also set up an alternative to competency restoration. So now if you are arrested on a felony in Dade and it's a nonviolent offense and you're not looking at any serious prison time, instead of putting you through the competency restoration system, which as I mentioned is such a waste of time and money, we put you to this program that's local. And instead of focusing on restoring you, we focus on reintegrating you and we focus on stabilizing you. Once you're stabilized, we then put you on our felony diversion program. We monitor you for another year using more of a traditional mental health court at that point. And upon successful completion, again, in most cases, the charges are dropped completely. What happens is if you go into our program, we transfer you to the crisis unit. And if you agree to go into the program, we do not rebook you. We pick you up at the facility. We take you right to the courtroom. And when you get to the courtroom, one of our 8 peer specialists are waiting for you. And these are people with lived experiences. 4 of them are graduates from the program. The county gave us a car to transport. They have food, they have clothes, they have something to drink, they have their medication. Housing has been arranged and everything is set. And the peers do this amazing job. I so encourage people that when they're looking to do these programs to make sure that you have a peer. The peers are amazing at helping reestablish relationships for this population, which is key to helping people into recovery. What happens is, I call us civilians, people without lived experiences, don't really get it. And we think, oh, if they just take their medication, they're going to be fine. That is so far from the truth. So many of these individuals, by the time they get arrested, not only do they have a serious mental illness, they have clinical depression. They don't care if they breathe. And what the peers do is help reestablish the relationship to incentivize them to want to start to get better. And that's what makes all the difference in the world for our program. And that's why I believe we have been so successful. Look, we've been successful with about 70 to 80% of the people we've tried to help. And so as good as this has been, there's still some limitations because the state mental health system in Florida is too fragmented, too under-resourced, too antiquated. Our laws are old and antiquated. They do not reflect modern science and research. And so We know that for about 20 to 30% of this population, those high utilizers, like I talked about, those 97, don't have any capacity in the community. So because we've been able to save our community so much money, they've reinvested a lot of it. In fact, they passed a bond issue. They gave us $51 million. And we are just about done building the first of its kind mental health diversion facility in the United States. This is a one-stop shop facility that offers all the essential elements of recovery in one location. And it's what we call a medical home. So it's going to have a receiving facility, crisis stabilization unit, a short-term residential facility, a primary health clinic, a dental clinic, an eye clinic, a podiatry clinic. It's going to have a day activity program run by people with mental illnesses to teach self-sufficiency. It's going to have a culinary supportive employment program to help people get job skills so that they can get jobs when they leave us. It has 200 beds of housing. It has a courtroom in the building. There will be trauma services. And the whole idea is, instead of just kicking people to the curb and discharging them to the street once we've adjudicated them, their case, we're going to gently reintegrate them back into the community, just like we would do if someone had a hip or knee replacement, for crying out loud. Why don't we do that for people with mental illnesses? We discriminate against people with these illnesses, and it's time to stop. And we hope it'll be open early next year. And we know that once we do this, that we will finally have the final missing piece in our toolbox to provide this complete array of services and truly help people, get into recovery. Look, the current shortcomings of the community mental health and criminal justice and juvenile systems did not arise recently. They did not arise as a result of any one stakeholder's actions or inactions, or any one party or one person or institution. None of us created this alone, and none of us can solve this alone. We all must be part of the solution. And if we're able to do this, I strongly believe we will finally achieve what the Supreme Court wanted us to achieve when they ordered deinstitutionalization of our hospitals. Thank you all very, very much, and I'm happy to take some questions.
Thank you so much, Judge Leifman.
How are we on time?
We're doing great. Thank you so much. Do we have any questions? Raise your hand and I can.
So I answered every question and no one has any questions. You're all ready to go change your systems now, I hope. There we go. Hi, Lisa.
Hi, Judge. Good to see you again. I'm from the Cuyahoga County Prosecutor's Office, and we came down to see you a few years ago. We're in Ohio.
You guys are great. Have you made any?
Oh, and we were most gracious. We've made some changes here. We now have a diversion center in Cuyahoga County for all of our police officers, and we're taking police are taking misdemeanors and some lower level felony offenses there, which is great. And it seems to be working well. It's just new as of this May. We cut the ribbon in May, so we patterned it after everything that you did. So I just wanted to say thank you for that.
Well, thank you. You can tell everyone on this thing that you actually saw what we do, so I didn't make anything up today.
Oh my gosh, it was, yes, that was exactly what we heard when we went down there. And I'm so glad that your center is going to be open early next year, because we toured the old facility that had been used as a mental health facility that you're now turning into a beautiful place. I'm just so happy.
It's almost done. It is so gorgeous. In fact,
that's great.
Vincent, did I send you a link to the website?
Not recently. I know I've seen it.
All right, I'll send you, I'm not sure. I'll send you a link if you could send it out to all the participants. Sorry, I didn't mean to interrupt you, Lisa. You'll get to see what it's starting to look like. It's gorgeous.
I can't wait to see it. We were there and we saw it was filled with old furniture and archaic medical equipment. It was scary.
The old Competency Restoration facility.
Yes.
This is a much better use.
Anyway.
So my question is, I know that you put some felonies into your program. And my question is how that's working. And we are not reluctant to do that, but we're concerned about doing that, especially when we have victims in some cases. So we're just wondering how it's working with your group of felony offenders.
Sure.
Who are in the program.
You know, I think we make a little, and I include us, by just judging these cases by their charge. What we do is when you are assessed, when you are arrested and you're assessed for our program, we do 3 assessments. We do a psychosocial to determine the level of the illness. We do a criminogenic risk assessment from Ohio. So right there, you should be able to get it. It's called ORAS, O-R-A-S,
Yes.
for the Ohio Risk Assessment System. And
Right.
it's free, it's validated, and it gives us a really good idea of their criminality. And we do a Texas Christian University drug screening to get an idea of how severe their substance use disorder is. And the key is to making sure that you get the right kinds of treatment around them, not what they're charged with. We, of course, exclude the big 3, murder, rape, and arson. That's just, it should not be, we shouldn't even discuss that, right? It is what it is. You know, this program is never about not prosecuting or not putting people in jail. It's about putting the right people in jail and keeping the right people out. I've had people charged with misdemeanors that scared the living daylights out of me, but they were just charged with a misdemeanor, and they were some of the most dangerous people. I've had people charged with, you know, felonies that wouldn't hurt a lamb. And so the key is really just assessing who they are and what their needs are, and if they have any prior history of violence. And if they do, we don't take them. And so it's more of about doing a full workup than what their charge is. And I'll tell you, it's working great. Look, when we started 21 years ago, our prosecutor was reticent to do misdemeanors. So we started with nonviolent misdemeanors. And within a few years, recidivism dropped. People got better, you know, and then we went to all misdemeanors. And then about 8 years ago, we started doing nonviolent felony cases. And even that has stretched a little bit because the charge sometimes sounds worse than it actually is. And we dig a little deeper. And Florida has a constitutional amendment that requires victim approval for certain things. So we're very good about reaching out. But I will tell you, a lot of these cases are domestic violence related. And what the prosecutor found is that the family will only go forward with the prosecution if they're allowed in the program. And didn't want to prosecute at all. So, you know, because they don't want their loved one in custody, they want them helped. And so it really depends. And we just do a very good job evaluating case by case. But our recidivism of our felony diversion went from 75 to 25%. And it saved the county 84 years of jail bed days. And I will tell you, this is the other counterintuitive piece. The felony cases are a lot easier than the misdemeanor cases. The reason that is the misdemeanors are much sicker. And those are the people that have been psychotic, untreated for decades, and they have permanent brain damage. It's that homeless guy that you see in your misdemeanor court every day that nobody knows what to do with. And so we have a new program for that. I don't know if we were doing it. We were not when you were here. I'm going to talk about that in a second. So thank you for reminding me that. But I will tell you, the people charged with felonies don't have the deficits that a lot of our misdemeanors have, and they're more amiable for treatment than the misdemeanors. They have more insight, they haven't been sick as long, and they've been easier to treat. The misdemeanors, you know, we know there's a lot of research today, and it's not for everyone, and the research is very interesting. It seems to indicate, and it's not complete enough for me to make this a factual statement, but I'm telling you what it's showing at this point. People with bipolar psychosis seem to have more permanent brain damage than people with schizophrenia psychosis. And so for people that are going long-term untreated, that just live out on the street committing quality of life offenses, they lack insight to their illness. Their gray matter has gotten destroyed in some cases, and they're much harder for us to help. So what did we do? We got the legislature to change the law on assisted outpatient treatment, which is a civil law. And we got permission. Well, what the legislature did is they extended jurisdiction, and county court criminal judges now can use the civil AOT law in our misdemeanor court. And that's those 15 people I was talking about at the beginning. It is amazing. Our biggest problem is finding housing that we can put them in because they've burned so many bridges, and that's why we need the new building. But what we do is we put them on a long-term injectable medication, and within 2 or 3 weeks, they're like a different person. And it's amazing. The recidivism's dropping really well for them. We do a whole wraparound. We got about 1.7 million from the legislature just for that population. And they needed an AOT program. They're just too sick for the existing services. And so that's what we do. And, you know, and the long-term injectable is great. It seems to have less side effects. They stay on it longer. It doesn't, the efficiency, the effectiveness doesn't drop off after they miss a pill because it's good from a month to 3 months. And it's really, really a good program. And it's going to be a lot bigger once we have the building open. So to me, going back to your first question, it's less to do with felons and misdemeanors. It's more to do about who they are, their risk of dangerousness, their risk of reoffending. We don't care so much if they have a higher risk of reoffending. It just means that we need to make sure that we are providing cognitive behavioral therapy on top of their serious mental health treatment. It's the people that we're concerned about that could be dangerous we're keeping out of the program. And there are some new risk assessment tools that have been developed at North Carolina State by Dr. Sarah. She just took over Policy Research Associates. And so I'll get you, Vincent, her name, and you guys can maybe see if you can get a hold of those tools. So I really think it's about screening out violence versus what the charge is.
Great. Thank you so much, sir. We owe you a lot.
No, you don't. You make me
I'll keep you
knowing that you're doing all that work. So I owe you.
Well, I'll keep you posted on the success of our diversion center. Thank you.
Congratulations. It'll just keep growing and getting better. Trust me.
Yes, I hope so. Thanks.
And the county of Miami-Dade and Mayor Daniela Levine just gave us $10 million in ARP money to open the new center. And the city of Miami and Mayor Francis Suarez gave us $1.4 million in ARP money to contribute towards the operations of the facility. We have 800 homeless people left in the city of Miami, and they're expecting us to help get rid of that. And so I'm telling you, get those federal dollars while they're out there. This is the perfect use of them. Don't spend them on the same crummy system that doesn't work. Use it for something new. Thank you. You're on mute, but I hear you.
That was one of the first things you said to us is don't keep using your money to house people in jail. Get them treatment and put them into diversion centers and programs. And so we're learning.
All right.
Thank you.
Thank you.
Thank you, Judge Leifman. We're running a little bit behind, but if you have time for another quick question or two.
Sure.
With some questions in the chat. We have a question about what the estimated operating costs of the diversion facility are.
So this is a big center, and we're very blessed. We have the Boston Consulting Group has a huge facility here in Miami, and they're very altruistic and very philanthropic. And we took them on a tour of our facility, and they fell in love with it. And they contributed probably at least $500,000 in pro bono services, and they just finished our business plan. So this is what we know. The actual operating cost annual is about $30 million. However, at least half of that will be made up in Medicaid money and insurance. And so the gap is going to be between probably $10 and $15 million a year. And we are working with the county and other resources to fill that gap. But remember, doing things the way we currently do it are very expensive. more so than 10 to $15 million a year. We believe that this project will save the county at least that much money annually as we move forward by over time, reducing the number of people in jail with mental illnesses and keeping that others from going back in. So we're all spending it one way or the other. And the real choice is, do we spend it in a way that's effective and helps people recover and promotes better public safety, or do we just keep doing the same silly thing and letting people cycle in and out? And so far, my county is getting it. It's helped to have those federal dollars, don't get me wrong. And we're in a lot of discussions right now moving forward how we're going to do this. But we're also very blessed. We're working with Columbia Psychiatry Department at Columbia University. They're coming down next week and they're helping us set up our clinical operations. So we're doing everything in our power to get this right so that we can show the rest of the country how to do it, that will really work and really save money, and make sure that we have research in there as well to make sure we measure everything that we're doing.
Thank you again so much, Judge Leifman. I think in the interest of getting you to the airport on time and us moving along with our agenda, we better move on to our next item. But Judge Leifman's been super accessible, and I know would be willing to speak with any of you further if I don't mind offering your ability that way. So.
Absolutely, my pleasure, and especially prosecutors, because we need you. And thank you for doing this. And I'm so proud that all of you are here. And Lisa, thank you again for making me feel so good. And you all stay healthy, stay well, and we'll be having real tours of our building relatively soon. So come to Miami, particularly in the winter. It's beautiful. All right, be well, everybody. Take care and enjoy the rest of the summit. I'm sure it'll be terrific.
Thanks for all you do. Safe travels.
Thank you.
Good to see you. And thank you to my colleague Gwendolyn for putting the link in the chat to the new Miami facility, the judge.
Vincent, can I say one last thing?
Please.
Because I really need to give Equitas a major plug.
Thank
We
you.
have been working for the last 3 years on developing a model civil code, and we got so much work done. And I want to thank Gwendolyn West, who's on, and Adam Goss, who are on, and of course, Vincent and the rest of his team, who have just done amazing work to help us facilitate it. But we were able to get so much done. We've also developed what we think is a model criminal justice pathway. In fact, I'm going from here to Savannah to talk to probate judges, because we think we should be creating a system that when people that are low risk, low need on low level offenses, that instead of even having a mental health court in some cases, we should be transferring those cases to the civil probate division and letting the civil court provide them with treatment alternatives instead of a criminal court. And we hope to be releasing that by the end of the year. And we hope you'll take a good hard look at it and maybe adopt that as you move forward, because I think it's going to be good for all of us. And that truly will be decriminalizing mental illness. So thank you, guys.
Thank you so much. Good to see you. All right. Well, thank you all. We're going to move along. We've got a busy day and so many great presentations line up. Without any further delay, and thank you so much for your patience, I'm going to introduce Michelle Onken, who's the division chief in the Mental Health and Child Fatality Division of the Harris County District Attorney's Office in Texas. Welcome, Michelle. It's all yours.
Hi. Thank you, Vincent, and thanks, everybody. That's and sarcastic thank you for putting me after the judge. That's never fun, right? That was an amazing presentation, though. So I guess good afternoon to those of us that are Central and East, and good morning to some of y'all in Mountain and California time. So I am going to try real quick to make sure I can share screen. Looks like it worked. All right, everybody good? Can see that okay? And how's the volume? Not blowing anybody out? Okay, great.
Great.
All right, y'all. Love it. Love the hand raise and the whatnot. Also, Vincent, for questions, do you want to wait till the end?
Whatever you're comfortable with, that's totally up to you.
Honestly, I'm easy, but if the end works for y'all, then that might be a more efficient way to get through.
All right.
Okay, so again, Harris County, Houston, Texas. We are really big, and I was just looking at our census and data from this last, or population from this last census. Yeah, we're still really big. 4.7 pushing 4.8 million, so third largest jurisdiction. And I will just say one thing, we've got a lot of big jurisdictions here, maybe smaller jurisdictions. I was looking at the chat and some of the conversations, and that's clearly a real issue, right? To sort of figure out, are you rural? Are you more of the big city? How big? What are your resources? But even the larger jurisdictions like us, we have resources, but I mean, I talk about our neuropsych center. We have 4.7 million people, but 30 beds in our neuropsych. So that's great that we have 30 beds, but gosh, that's still not going to do the trick, right? So we all have a lot of challenges, but we are doing some really great things. So I want to talk to you about our mental health diversion center here in Harris County. So to start off with, so you see some photographs here, and this is actually our original facility, and our diversion center has moved in a different facility that I can't even go into today, but our LMHA, the Harris Center for Mental Health, they have done some really cool things. They run our diversion center, and they've put it with some other really wonderful programs, but this was the original one. So those are a lot of the photos that I have. So we are pre-charge. That's what we call it. Now, a lot of people call it no charge. Sometimes when I hear that, I feel like we're not asking people for money. So I'm like, no charge, that sounds like it's free, but that's not what we mean. Others call it a deflection. So we are using pre-charge, but mean no charges ever. No one's ever going to come on the back end and get charged later. Okay. So that's why I did no charge in all caps, but we refer to it as pre-charge. Ours is all misdemeanors, no felonies. And again, we're focusing on the nonviolent aspect, and we're looking at any violence or public safety issues that exist with that individual. We opened this facility September 4th of 2018. So we just passed our 3-year mark, which is very exciting. And initially, we just focused on exclusively criminal trespass as an offense. I'll talk more about that. Then, because things were going really well, in May of 2019, we decided to go ahead and include some additional offenses, which I'll also hit that in a little bit. And we're open. I mean, our facility is open, ready to take people 24/7, every day of the week. So it is, there's no limitations there because things happen at all hours of the day, as we know. One of the great things that our county has, like I'm sure a lot of y'all do, is cooperation, the stakeholders coming together, meeting of the minds. Well, okay, not always a meeting of the minds, right? But at least a conversation. And we have our Harris County Criminal Justice Coordinating Council, and there is a subcommittee, the Mental Health Subcommittee. And out of that subcommittee, over years of just kind of frustration and trying to figure out there's got to be a better way, right? What we're doing is not working, so let's figure out something different. All of these different agencies were represented in that subcommittee, and we call it the Mental Health Standing Committee, which is a subcommittee of this coordinating council. And all of these groups that you can see here for yourself are two big law enforcement agencies, the county judge for whom the center was named after. And anyway, just everybody coming together to do it. Look how they're like having a party. They're so excited. This was the ribbon cutting for the facility. So anyway, it takes a village, it takes a lot of people to get together to be on the same page, right? It also takes money. I know we're not ignorant or too naive to understand that. So obviously it takes money and some great supporters. So we had some great representatives and senators in our state legislature that really backed us in this and were, good enough to really know how important this was. So we had a Senate bill and a House bill, and we got, several $1 million. And unless I've, slept too long since then, I believe this was for the first 2 years of operation, the numbers that you're seeing here. We also did in-kind matches, basically the services of the sheriff's office. They're dealing with obviously what's happening in jail, but also these people don't go to jail, but we tried to do also create a second catchment. So if someone did go to jail, maybe we could even have a second opportunity to see them and say, whoa, let's back this out and go the other direction and go to the diversion center instead. HPD, our Houston Police Department, has ended up being our biggest customer for our diversion center. So much thanks to them, the Housing Authority, and obviously the Harris Center, our local mental health authority. They run the diversion center. So why a diversion center? I don't think I have to tell y'all this. I'm preaching to the choir in this group, I think. So like I talked about our neuropsych center, it's wonderful, but we didn't really have any other place to divert. And really we were diverting only those people who were emergent, who were so acute that they were in crisis. Back in 2016 and 2017 is when we were doing a lot of the research for this. And so really looking at stats and whatnot. And that's when it kind of just hit us that, we've got this nonviolent, low-level case, criminal trespass. You're somewhere where you're not supposed to be. We've got 85% of those individuals charged that either have mental illness or homelessness or both, which is very likely, as we know. We had on average at that point, 3,000 inmates in our county jail. They were on psychotropic meds every day. We know how expensive that is. We do in our state, different than Florida, we do have competency restoration on our misdemeanors. And so again, you can see these numbers, the 170 cases, misdemeanor class B is our lowest level misdemeanor when you're not a traffic ticket. We were, ending up with almost 12,000 days in jail because people were having to wait for a bed to get competency restoration. So one of the reasons that we started with criminal trespass was, as I say, we get a lot of bang for our buck. This is quite literally the most frequently filed nonviolent case with the biggest percentage of mentally ill individuals that are involved in those kind of cases. And doing the research, we determined 60% of the individuals filed in a year or two while we were doing our research filed for criminal trespass have a mental illness. So we just realized, hey, this is the place to start. And just anecdotally, it was obvious from being in courts. And this is obviously where we see that intersection that we all know about: mental illness, drug addiction, and homelessness. And the typical case here that I've listed out, a homeless person diagnosed with fill in the blank, whatever diagnosis you can think of, and they're hanging out at a convenience store. It could be your local 7-Eleven. It could be a grocery store. It could just be, a restaurant in the downtown area, whatnot. And they're looking for food. Maybe they're panhandling. Maybe they just need a place to sleep and they've been asked to leave. And, hopefully they're not harming anyone physically, but certainly I know that it can be distressful to individuals that are running those establishments. But obviously this is something that maybe we can get to the root of and change, and this won't be happening again. And this is just the criminal record. I know y'all have seen this a lot of one of our very frequently utilizers. I counted at one point 46. That's just what's listed on the screen. Almost every single one of them a trespass or a low-level nonviolent misdemeanor. So obviously it is time for a new approach, right? This revolving door in and out of our jail, getting arrested, maybe doing 3 days credit for 3, which is what's happening in our county, it's not solving anything, which again, I'm preaching to the choir here. So talked about why we looked at criminal trespass. In our local rules for bond, a trespass, and other nonviolent misdemeanors, the local rule says they're going to get a PR bond and they're going to just be, let out the back door of our jail or our joint processing center. No meds, no treatment, no connection to services. They try to, have a good exit strategy at the jail, have people there from our local mental health authority. But sometimes a pamphlet is not going to cut it, right? And they're just right back out there sort of wandering around downtown like they were before. Another thing that we really try to explain to law enforcement, if in the beginning there was some pushback, but trying to explain they're getting out and this is what's happening. They're not staying in jail, which sometimes law enforcement thinks is a good thing because they want to protect their complainants, which I respect, wanting to protect our victims and our community. But I think that, like we said, people think, well, you can force some sort of help on someone or it's automatically they're going to get treatment. They're not. It's voluntary, even when charges are filed. So our program's voluntary, but hey, I mean, you have to sign up for a probation even that involves some sort of mental health docket or caseload. So really it's all voluntary in this system. And again, it's immediate. They're going to get meds, they're going to get assessment, treated, whatever they need at the diversion center. So a lot of times as prosecutors, we want to know, well, who's eligible? What are your, restrictions? Who's eliminated from the program? So you can see on here, again, low-level nonviolent. They have to have a history of mental illness, or if we cannot find a history of mental illness, if they appear mentally ill. And our officers, thank goodness, are getting more and more trained and better at recognizing that. And sometimes it's pretty clear and obvious that this person has some sort of mental illness. And we require, and it makes sense, of course, as lawyers, we understand that there's a nexus of some sort, but you can't get in anyone's mind. And I think it's really impossible to say, oh, mental health is absolutely a 52% contributing factor to this conduct. We're never going to know that, right? We're just taking our, educated minds and our common sense and trying to figure that out. Big thing, again, we're looking at public safety threat. And I think that really making it clear to our community that we focus on that, respect that, and take that seriously has helped with buy-in from the community and other stakeholders, especially law enforcement. Of course, if an individual is in acute crisis, the diversion center is not where we want them. We more likely need to get them over to our neuropsych center or do some sort of an emergency detention order if they're a danger to themselves or others. We need to get them to a higher level of care and treatment. It's voluntary, okay? That's been a challenge, but can't hold anyone against their will. Not going to do that. So it is voluntary for 18 up because they have to consent to treatment. So that makes sense, right? We also looked at who was not eligible. We didn't want to limit ourselves and say, well, we're just going to pick these 8 offenses that y'all can look at. We tried to think of some crimes that we see frequently in our mentally ill population and kind of talk to our prosecutors about, well, maybe these are ones that you might see when you're looking beyond just trespass. But let's talk about some ones that maybe just we can say per se, not really going to be appropriate. But I will tell you this as a caveat, I have never fussed at anybody for filing, let's say, a terroristic threat. That's basically like, well, I don't know what words I can say on this. I'll edit myself. Hey man, I'm going to kick your butt. Nobody says that, right? Out on the streets. But a lot of times when it's a big old giant security guard and a frail, fragile, mentally ill person says that, that security guard does not think that is a very serious threat. It's not the greatest case. I am more than happy for this person to be diverted. So, I'll just put that out there. But these are pretty obvious, I think, because of their more violent nature, especially the family members. Now, I will say, though, focusing on family member in this context, we're really talking about interpersonal violence and everything that goes with that when we say domestic violence. But truly family, household members, those loved ones who are right there during the crises, who desperately want help for their loved ones, that's also become a bit of an exception to this rule. Sometimes the ones that I don't want my loved one charged, I just don't know what else to do, right, than to call the police. And maybe there was a push or a shove. No, we need to get that person help and get that family put back together. All right, so those kind of speak for themselves. One note, though, again, probably obvious, if someone has an open warrant or some sort of legal detainer, the officer can't divert them and take them somewhere other than jail because they have a duty. If they run someone and see they've got an open warrant, whether it's for a traffic case that they didn't go to court on or a murder, obviously they have an obligation to take that person into custody and execute that warrant. So that, of course, makes sense. So here's the thing. I've spent my entire career, 27 years as of this month, which I can't even believe myself. It's kind of blows me away. But I've spent my whole career here in Harris County as a prosecutor. I didn't know that we were such unicorns in our intake process. So we have a 24/7, 365 intake process where prosecutors are physically manning an office and phone lines to discuss cases with law enforcement officers and to make charging decisions, or to say, go back and keep investigating, call back later, once you've done this, that, and the other thing. So we are very lucky in our positioning that way, that we have this ability to be able to talk to these law enforcement officers right on the scene. So here's what we're doing is, in addition, so we're there, we've got our computers, we've got our phones, and on our criminal history search in our own internal system, if someone's been through, if they've been arrested and charged Class B or above, we've got a connection to something that we call an orange sheet. And that gratefully was connected through our sheriff's department into our system electronically, and it summarizes all of their records, any mental health databases that can be combined together, and our prosecutors will know. So officer calls and says, I'm out here with a man behind the stop and go. He's disheveled, he's panhandling. The prosecutor goes, ding, ding, ding. I wonder if that individual has a mental health record. They run them. Oh, I see Mr. So-and-so has been diagnosed previously for whatever things. We can actually see the diagnoses. So we know right there on scene, for anything, the prosecutor is going to say, do I accept, decline? We don't decline in these cases, or would I divert charges to the Mental Health Diversion Center? And what I just described, yes, the prosecutor would say we're going to divert. Obviously, if the person is doing really poorly, we've tried to do several trainings with our prosecutors about emergency detention orders. The officers all know about them, but hey, if this person is a danger, we don't need to be filing on them. We need to be, getting them to the hospital. So again, that higher level of care, but in itself, it's also a diversion, right? It's again open 24/7, and we are there 24/7 to have those conversations with law enforcement. And they're used to calling us. They have to call us, on every case if they want charges. And the officer then, literally they'd still be at that stop and go parking lot. They call us, they have that conversation, okay, and they just would deliver the individual straight to the diversion center. It's a quick 10-minute sign-in procedure on an iPad, and then that officer's back on the street doing their, their normal patrol and back to some more serious calls. Again, voluntary program. So if the individual says this, if this situation is stressful for them, obviously these are trained individuals. It's their job to engage, but we know with the mentally ill population, that's not always easy. So it might not be their first visit there. It might be their second or even third visit there before they are really engaged to stay, but they do everything. They're so creative. They're baking cookies in the back. They have a popcorn machine. I mean, anything, hey, we'll let you take a shower, come lay down for a little bit, just try to, rest, whatever it is, to get them engaged, to make them feel comfortable and safe. And again, criminal charges are not filed at that point or at any point. So here is the break room in the diversion center, and basically standardized intake flows. And I mean, intake there at the center, not DA intake. Peer support, huge, like the judge talked about. There's not just mental health assessment, but medical health assessment, which we know a lot of individuals have not had in years. So very important. Nurse does a triage there. Psychologist or psychiatrist does an evaluation. We do telehealth if needed. If the psychiatrist, is needed at 2 a.m. Again, internal medicine and master's level clinician. So they do a great assessment up front, and they're on site. You can see all the wonderful services that they do. This was the lovely courtyard in the first facility. And I mean, truthfully, we talked to them about everything from take them to the courtyard and let them, relax before you go inside if they seem agitated. If they're demanding a cigarette, somebody find them a cigarette, let them go outside, and like whatever to make this person feel comfortable and not stressed and afraid to stay. So you can see all the great things on site that is there. And again, offering them housing is also huge after the assessment. And there are 30 beds at the current version of the facility, in addition to kind of an assessment area or an observation area where people can relax in recliners. So, and then aftercare, which is huge. That's also voluntary, but we can make a huge impact with aftercare and continuing to get people services and stable housing. And I'd say about 28% of our people do the aftercare program. Here are all the great things, and y'all are going to get this PowerPoint, so don't stress. It's going to be up on the link that Vincent talked about before, but just great things that they can be connected to, and including, like you can see, for individuals who have the co-occurring disorder with substance abuse, getting them into some great treatment facilities that we have here locally. So just sort of the evolution of the program. Again, we started with Trespass initially. And then back in February of 2019, we have a misdemeanor marijuana diversion program, also pre-charge. What we found with a lot of individuals who hadn't made contact and hadn't done the required class that they were to do for their marijuana diversion, we realized a lot of those people were mentally ill, and was likely the reason that they didn't do what was required of them. And so we decided to give that list each month to the Diversion Center, and they reach out to those individuals and offer them to get them involved in the aftercare program, not to actually go to the Diversion Center, but just hook them straight into aftercare. And then, as I said before, May of 2019, we're really thinking things are going well. We want to expand this and not limit it and say, well, gosh, you did a criminal mischief, meaning you broke someone else's property or damaged that property, you don't get to do this program. That's silly. So we open it up to other cases. And then finally, just in June of this year, a few months ago, we decided, let's have a post-charge opportunity, even after charges are filed, again, as another catchment area, because we in our mental health division, maybe we're even more uber focused on these. And granted, everybody can have a different opinion on a different day, but being a little bit more trained in it, we're looking at these cases that come in as well and just putting another set of eyes on it, and then letting our misdemeanor courts know, hey, you should look at this person and talk to their lawyer about doing a diversion. And that person would just go to the diversion center and get involved in those same kind of programs that we talked about are being offered. So just another way to get more people in that maybe were missed at the intake stage before charges were filed. And I won't belabor this, but these are some of the examples that we give when we train our prosecutors about cases to look for other than trespass. Again, criminal mischief, it could be, they kicked one of our Metro bus doors. The low-level thefts that have a prior, then in our jurisdiction, that's going to be a Class B or above, a jailable offense, but they're maybe stealing snacks at the local gas station. And these are all like real cases that we took examples from. One very, very sick individual, actually the one who's, I showed you his record earlier, the 46 plus, honestly, probably 80 or more charges, a very sadly sick individual. And he stole a coffee pot from a downtown business. And I mean, this poor man he doesn't have anywhere to plug in a coffee pot. So this is not a vindictive, kind of thing. This is just a very sick individual. Oh yeah, that was right in front of me at an urgent care clinic. I mean, poor man. Obstructing a highway, panhandling. I mean, y'all, that kind of all makes sense. Not identifying themselves. This person who said they were Jesus Christ, they were not being sarcastic, they were not being a jerk. Interfering with an officer's duties, or just, getting in the way maybe when there's some sort of traffic stop happening. And then false report to a police officer, like when someone calls 911 and, says that someone's zapping my brain. And again, they're just a desperate person looking for help. All right, in most of our cases that we divert are still criminal trespass. Another thing that's cool is that our officers, they can actually bypass our DA intake, which we usually don't allow, but for this reason, we want them to want to do it. And at first it was kind of like pulling teeth. They were a little bit resistant. Now we see more officers just saying, oh yeah, this is a case we divert. I'm just going to directly divert them over to the diversion center. And we also take Class Cs. So just trying to get as many things diverted as we can. And just sort of wrapping up, this is always a big issue, right? How are we doing? How do we measure that? So we just finished the end of the third year of operation. That was in August of 2021. And so we had over 4,200 diversions in those first 3 years. And a wonderful group called Justice System Partners out of Ohio, but the man who heads it up happened to be the second in charge of our probation department, or previously. And so what was great about that is he had a really good basis of knowledge about how Harris County works. So we didn't have to sort of start from the ground floor, but they did an independent evaluation of how things were working. And I think this first one is for people involved in the program, a 50% reduction in their new jail bookings for individuals who had gone to the Diversion Center. I'm not sure, do y'all need me to stop, or somebody just having a chat? I just want to make sure we're good. Vincent, we're good?
Yeah, thanks, Michelle. I think that was just somebody who went off mute for a second.
Okay, all right.
Close on time.
No, we are. I am almost done. Again, more for math people, other ways of saying that the bookings really went down. But here's a big one for a lot of people, especially the money people in your county. They found that for every dollar we spent on diversion, the county avoided spending $5.54 on criminal justice associated cost. So that's a really big deal, I think, and something that can really sell programs to the money people in your county. And just graphs that show a nice, slope off of bookings for trespass cases after the diversion center opened, and just a drop in cases for people who had a history with our local mental health authority. Again, I know that we're short-ish on time maybe, but if there are questions, I'm happy to take them.
Michelle, just in the interest of time, and thank you so much. And I know it was
No worries.
It's not that you went over, we got behind already with Judge Leifman.
I understand, no problem at all, but y'all can, type in the chat or whatever. It's all good. And then I'll put my email in the chat as well.
Thank you. I was going to suggest, and if I think you're going to be with us for a bit, we may catch up and have some time.
I'll be with you all day.
Awesome.
There we go. There's my stop share. Okay. Thank you, everyone. I appreciate it.
Thank you so much. And thanks for being with us. And please, questions for Michelle in the chat. And we'll maybe have a little bit more open time if we catch up a little bit. And I apologize for the compact scheduling. Anyway, I want to next introduce Tony Martirosian, who's the Alternative to Incarceration Chief in the District Attorney's Office of Manhattan. Thank you for being with us.
Thank you, Vincent. I'm so happy to be here. Good afternoon to everyone. Let me just see if I share my screen. All right. Can everyone see that? Can you see the?
Yep.
Yep. Okay.
Yep.
All right. So in the interest of time, I'm going to try to move very quickly. I apologize if I talk fast or glaze over some things, but you'll have my contact information if anyone has any questions after today's presentation. So, in Manhattan and in New York City, I always say we're a bit spoiled because it is a very treatment-rich environment. And I understand that not everyone has as many resources in terms of available treatment as we do in New York City. And so the DA's office has a variety of misdemeanor and felony diversionary programs. I've listed a few here. Our Manhattan Justice Opportunity Center was something that launched right at the beginning of the pandemic. And it very much is a one-stop shop for folks who are charged with misdemeanors and for their friends and family members to receive all sorts of referrals, social worker services on site. Largely our misdemeanor practice has changed considerably since I joined the office about 15 years ago. It's rare that someone is incarcerated on most of the felonies, trespass, criminal possession of a controlled substance, petit larceny. And so the way that kind of the criminal justice system has reacted or responded to that is we recognize those are opportunities for light touch programming. And by that, I mean, in cases where we saw, frequently folks getting time served, like a trespass case, sometimes the office would recommend community service, which really did very little to address the individual's criminogenic needs or what it was driving their criminal behavior. And so things like the Manhattan Justice Opportunity Center were created to offer folks light touch programming services. Again, in response to how the criminal justice system was largely treating those folks was time served dispositions. And so today, what I'd love to talk to you a little bit about is our felony practice and specifically our alternatives to incarceration court part, which unlike I think many of the kinds of cases we've spoken about already today is unique in that over 50% of our participants in the ATI part are charged with violent felonies. We take sex crimes, gun possession cases in the court part, obviously very serious cases that I think to most prosecutors would scream public safety concerns. But we've recognized that if we're going to make an impact on mass incarceration, we really need to be willing to look at violent felonies and see what we can do to try to divert some folks and address obviously the needs that are driving the criminal behavior. And so we also have many problem-solving courts, traditional problem-solving courts in Manhattan, drug court, mental health court, veterans treatment court. And so, obviously we very much viewed problem-solving courts as the gold standard when we first started learning more about this work. And by that, I mean, they're judges who really understand, or should understand if they're properly trained, the nature of substance use, mental illness, things like that. At least in Manhattan, there's usually dedicated ADAs that staff those court parts, so there's some level of expertise. And of course, there's clinicians who usually work the court, and they are monitoring our participants' progress in those problem-solving courts. They're doing assessments, recommending treatment plans. So all of that is great and wonderful. But in Manhattan, what we noticed was that not everyone fell into one of those problem-solving courts. And by that, I mean, some of these courts have strict eligibility criteria, including the charges, certain charges excluded from eligibility. Our mental health court requires SMI diagnosis, someone to be diagnosed as seriously mentally ill, which means schizophrenic, schizoaffective, bipolar, major depressive disorder. You can imagine that it's not always clear, depending on where someone is at the onset of their mental illness, or if there's co-occurring substance use issues, what is the primary diagnosis? Is it substance use? Is it mental health? So not everyone fits neatly into one of these problem-solving courts. The courts also were historically not able to deal with folks who had severe developmental disabilities. There was some, kind of different degrees of risk tolerance, I'll say. And so what we found was that, well-meaning ADAs and well-meaning defense attorneys, if they couldn't get defendant into a problem-solving court, they were often taking programming dispositions in one of our upfront court parts where there was no clinician. Usually it was the attorneys who were driving the show in terms of where the person was referred for treatment. The participants were appearing before judges who didn't really understand the nature of addiction, the nature of, kind of struggling with mental health conditions. And so, and another is, we found that the treatment was not always responding to the need that was driving the criminal behavior. There was a heavy emphasis on substance use treatment, because I think that's what most defense attorneys specifically were educated in. But if you had, for example, like a straight mental health issue, and for some reason you weren't eligible or able to get into mental health court, you may be sent to to treatment, even if that wasn't going to really address the underlying mental health issues. And so the HCI unit was created to try to, get our hands around all of these dispositions that were happening outside of the problem-solving courts. And we wanted to make sure that, principles, best practices like procedural justice, adherence to the risk needs responsivity model, all of these things you can see listed. We wanted to try to create a unit, and then in time, a court part that would fill in the gaps that the problem-solving courts were missing. And so the alternative to incarceration part was created. I should say the unit was created, and then we worked with our stakeholders, the defense bar, the Office of Court Administration, and eventually a clinical team that worked for the Center for Court Innovation. We all came together and we decided to create this court part. As you can see, there's no exclusionary criteria. And by that, I mean, we receive referrals on a wide array of felony offenses, and we look at every case individually. The needs addressed really, as you can see, they run the gamut. And as you can imagine, often our participants are struggling with more than one and more than two of these needs. In mental health court, we realized that we were getting a lot of referrals to the ATI part because the individuals had gone to the drug court and they did have a substance use disorder. However, the clinicians in drug court felt that they also had a co-occurring mental health issue, and they weren't trained or equipped to deal with that. And so one of the things that our office worked again with our stakeholder partners to create a mental health track in our drug court. So now there are clinicians who really specialize in working with folks with co-occurring disorders. And so that's something that the DA's office was able to fund with forfeiture money. Our ATI team meets every 2 weeks with the bureau that runs mental health court, and we talk about different applicants who have come through our doors and trying to figure out what the best venue is to service them and to address their needs. You know, one thing we see a lot of is personality disorders, and a personality disorder, it doesn't get you into mental health court. It's not an SMI diagnosis. And so, as you can imagine, we've worked with our clinical partners in the ATI part to try to find out, try to learn best services for people who have personality disorders. It's been discussed already today, but as you can imagine, almost everyone in the ATI part has significant trauma. And so the clinical team is always, when they're coming up with treatment plans, trying to address the underlying trauma that gave rise to so much of the issues, so many of the later issues that we see presenting in these folks' lives. So just, I think this is probably the most relevant slide for most of you who maybe are thinking about trying to create a similar felony programming court. The way it works in Manhattan generally is the defense attorney, who of course knows the client the best and knows whether or not they would be interested in participating in programming, makes a referral to the assistant who's assigned to the case, the trial division assistant. That assistant then reaches out to our unit, and eventually, while we're doing our own screening of the individual to find out what their history is like, what their needs likely are, can they be managed safely in the community? There's a needs assessment that's going on by the clinicians who work for the Center for Court Innovation. Again, that's the clinical arm of our court. And they're interviewing the applicant, they're speaking to community contacts, they're reviewing prior treatment records or correctional health records, all with an eye towards what type of treatment plan would hopefully keep this person out of trouble and get them the services that they need in order to avoid further involvement in the criminal justice system. There are some applicants who can participate in programming over our objection. I won't get into that except to say that generally speaking, those individuals could receive a non-incarceratory disposition on a plea to the charge. And so they can, there's just a few of them, because I'll be honest with you, overwhelmingly we're consenting to ATI dispositions on these cases. After the screen is done, there's a conference with all parties and the treatment team, and we hear about what they think is the appropriate services in the case. And then if the defendant is willing to engage, there is a plea agreement that's executed. The treatment mandate, again, reflective of the seriousness of these crimes, can be anywhere from 9 to 24 months of treatment. There are frequent court updates, both on calendar updates, and we've really built out our virtual footprint because of COVID. And so now, our participants have a lot going on. They're engaged in treatment, they have jobs, they have childcare responsibilities. And so a lot of times we'll be conferencing with them present and with the judge present virtually off calendar to see how they're doing, to commend them on the progress they're making. And at the end of successful completion, there's usually a benefit, and the benefit is moving more and more towards dismissal of indictments. For a lot of reasons, we think that makes sense. If someone has succeeded in this program, we have faith that they are going to go on to lead a law-abiding life, and we don't want to further hinder their ability to do that by leaving them with a criminal conviction. There are some cases, as you can imagine, that are so serious or that require orders of protection where we can't always offer the dismissal of the indictment, but that is certainly we're moving more and more towards dismissals. So public safety And let me say this just for a moment, because we are dealing largely with crimes that do involve victims. One thing that we always try to do is encourage our line assistants to speak with the victim and to explain the type of treatment that we're offering. I think that folks who aren't involved in the criminal justice system, they have varying degrees of what a programming disposition means. And many people, many prosecutors included, sometimes think that, oh, it's a slap on the wrist. And so we really try to explain to complainants and victims the type of treatment that we're talking about and exactly what type of commitment it's going to take from our participants to be able to succeed. And I find overwhelmingly when a victim understands exactly what will be required and what the consequences will be if the individual doesn't comply, they support a programming disposition. And that's because, in my experience speaking with victims, they usually say, we can't change what happened to that person, but they don't want it to happen again. And as Michelle and His Honor talked about, so often these involve parties who know each other, family members. I mean, they're going to be in each other's lives for better or worse forever. And so they want them to get the help that they need. I'll just say again, in an effort to really identify gaps, one of the things that we've recently launched, and this is a whole separate presentation, is an emerging adult track in the ATI part. Obviously working with young people and all we know about the brain science involved with that, it's different. It's different than working with 50 and 60-year-old men and women. And so in recognition of that, we partnered with Columbia Justice Lab to try to learn more and implement best practices for really dealing with the 18 to 25-year-old population. That's a population that I can tell you we struggle to get engagement from. And, that's something we discussed a lot during our meetings with Columbia. And so let me just quickly move on. Oh, hold on. Sorry. Leverage, one of the things that we find is often the really robust treatment that we do in the ETI part. Look, people are only really interested in it when they're facing significant jail time. And I think we all, probably have had that experience, and it's unfortunate. That's the leverage that motivates them. But often it is. And so again, it's in very serious cases that we can try to get individuals this really robust, life-changing treatment. We struggle things like insight. There are many sick people, as you can imagine, who just don't fully appreciate the needs that they have. They don't show a willingness to take medication. That's something that we struggle with. And then availability of resources. This is something I just want to spend a minute on. I mentioned personality disorders. We, hear from our clinical team that the best treatment for that is DBT, dialectical behavioral therapy. Well, for some reason in New York City, it is very, very hard to get DBT for people who are on Medicaid, which most of our participants are. So this is an area that, we've identified as something that we need to try with really the public health system to try to address. We've had some folks who have substance use disorders, but really what's kind of driving a lot of the substance use disorder is actually eating disorders, and which is a mental health condition. And it's very hard to find really strong help for an eating disorder when you're on Medicaid. One of the things I've found in the ATI part is our cases are dragging on a bit because, and someone said this before in the chat, recovery is not linear, and certainly it's not. There's steps forward, one step back. And I think that we're very reluctant to ask for sentence in a lot of cases because we are committed to trying to help the individual achieve, kind of stability, sustained stability, but it takes a very long time. And so sometimes the cases drag on. It's challenging. Another issue we faced is measuring compliance time. It's not always as, in drug court, traditionally, they kind of measure days sober. But in an ATI part where you're addressing things like sexual offender behavior and very serious mental illness, it's challenging to decide how you're going to measure compliance and compliance time. we've struggled, the court calendar has become quite congested. And, you know, for folks who really could benefit from frequent check-ins with the judge, we're having trouble getting calendar time. And so that's actually one of the reasons we're doing more of these off-calendar conferences, just to try to get folks, you know, before the judge so that they can receive the encouragement that they need. I would say other things that we kind of dealt with in the city and even in the office, things like culture change. You know, this idea that someone, I think the judge mentioned it before, you know, public safety and diversionary programming, they're not opposites. They're you know, very much intertwined, and we are promoting public safety by trying to help rehabilitate folks, even folks who are indicted on violent felonies. And so these are just things, you know, I'm sorry to rush. I know we're short on time, but this is just an overview, I guess, of our practice. And this really, I think, one of a kind, specifically tailored to the participant and the participant's needs court part that we've launched. And we're learning as we go, but we've certainly learned a lot. So thank you.
Thank you so much, Tony. And again, in the interest of time, we're going to keep moving, and please put questions in the chat, and the presenters can answer them in the chat as they're able. And we'll also gather up all the questions and then do outreach to folks and circulate answers in coming weeks as we get that together. And I apologize again for packing so much in today, but I really want to make sure that we get to our next presentation as well. Well, we still have them with us, and that's with Douglas Hobart, Long Beach City Prosecutor, and Deputy City Prosecutor Laura Reimer, if I'm pronouncing your name correctly. Forgive me if not.
I think you got both of our names correct. And by the way, thank you for inviting us. And I just wanted to comment on the diversity of the speakers. We started in Miami, Florida, and then we went to Houston, then to Manhattan, and now we're in Los Angeles County in the city of Long Beach. So we're going to talk about diversion from our perspective, and we're going to focus on prosecutor-led diversion. And I promised Vincent, since we're running behind, I'll try to get mine done in less time than we were allotted. And our information is at the end, so anyone who has questions can certainly contact us. I'm sharing my screen. Hopefully this will work, except my screen's not moving. Can anyone else see my screen moving? Oh, there we go.
Yep, looks good.
All right, so I apologize. Looks like there's a slight delay. So in talking about diversion, the word diversion has probably been used 50 or 60 times this morning, but I noticed it hasn't been defined so much. So I want to talk about what that means and what it means specifically to us as prosecutors. You know, when I first heard about diversion, I remember being at a meeting where a prosecutor asked the very important question, what gives us the authority to do diversion? Why aren't we required to simply prosecute cases? That's our job, right? We're prosecutors. Well, it turns out that there's a lot of authority, and it stems from the concept of prosecutorial discretion. This is information from a case out of California, but I'll bet you anything, your state has case law, probably not statutory authority, but case law along these lines, where a court basically says a prosecutor has enormous power and discretion to allege whatever he chooses at the time he chooses. That includes evidentiary sufficiency, which is a determination of how much evidence is needed before you file a case in court. It includes charge selection, a determination of what charges should be filed in court. And thirdly, a discretion to not prosecute the case at all. We do have that power, and it's somewhat unique as prosecutors that we have that power. So diversion is not defined anywhere in statute in California. It may not be defined in statute in your state. So I'm going to define it quickly in the broadest terms, because this is how I speak about diversion. I talk about diversion as the disposition of a criminal offense by means other than the traditional criminal justice process. Traditionally, we've responded to crimes with jail, incarceration. We've responded with fines and forced labor, sometimes, probation, particularly probation where there's oversight by a probation department. So those are the things that we traditionally have used to respond to criminal conduct. And over the years, we've added more things to the list of criminal conduct. So there are things that you cannot do today that were not criminalized, 20, 30, 40 years ago. So we've expanded the things that could result in criminal prosecution. And so really having those narrow things, fines, jail, probation, really doesn't make sense today when we have such a wide variety of crimes. So really diversion includes, to me, it includes pre-filing diversion. It includes diversion of a case that is already filed in court, but the sentence may be held. We call that deferred entry of judgment so that a person can complete a program. I would even argue it includes alternative sentencing, something that allows the offender to do something other than jail, other than pay a fine or do forced labor, for example, a rehabilitation program. I would put all those into diversion. And now even more recently, we've been talking about diversion at the street level using officers to divert cases as well. In addition to prosecutors having enormous power generally in the United States, I found that there's best practices printed up by the American Bar Association. In fact, if you search for criminal justice standards for the prosecution function, and by the way, there are criminal justice standards published for the defense function, but specifically talking about the prosecution function, standard 3-4.4 says a prosecutor should consider the possibility of a non-criminal disposition, formal or informal, or deferred prosecution or other diversionary program when deciding whether to initiate or prosecute charges. The prosecutor should be familiar with the services and resources of other agencies, public or private, that might assist in the evaluation of cases for diversion or deferral from the criminal process. So in the ABA's standards, which I would call best practices or guidelines, prosecutors are encouraged to become familiar with what programs are available out there in the public. This is particularly important for those of us who do not have large government-financed programs. We've heard about some of them today, and Judge Leifman, who has been very instrumental in creating these programs in Miami. A lot of us don't have those programs, but that doesn't mean that prosecutors cannot engage in robust diversionary programs. It just means that those programs may have to be prosecutor-led. In fact, a prosecutor may have to put people in the same room to discuss how these programs would work, almost create them our own out of whole cloth if they don't exist in our communities. But we have the power to do that through this concept of prosecutorial discretion. We have the ability to not file cases or to file cases only in certain situations. Prosecutor-led diversion, I'm going to advocate for us being in the driver's seat in diversion for a few reasons. Diversion, if done right, as we've talked about today, can decrease recidivism. It can make communities safer. It can reduce the court congestion that we see in courts, allowing the courts to handle more serious cases. It can also reduce costs to taxpayers, and importantly, it can improve outcomes for defendants. But prosecutors are uniquely situated to accomplish these goals because prosecutors have this discretion. Also, I would argue prosecutors have, I would say, the public trust. If the public defenders were in charge of diversion, no one would trust a system like that because public defenders, that's not their job to keep communities safe. Their job is to get criminals, out of custody onto the streets. That they look out for the legal interests of their clients. I would argue that prosecutors are better situated than police officers. Police departments are responding to immediate public safety crises. They make arrests, they will handcuff someone, bring them to the jail, and then they go on to the next case. But prosecutors are really uniquely situated because we have the ability the day after the incident, or sometimes weeks after the incident, to come up with a program that might be suitable for that particular defendant. We know more about the cases. We often will talk to the victims of the crime. We'll know the defendant's criminal history better than anyone will ever know them, particularly in misdemeanors, where things happen very, very quickly. We really are in a unique seat in the criminal justice system. And I would argue if we do not lead diversion, if we do not participate in and make diversion a prosecutor-led type program, somebody else will do it who is not so uniquely situated and is not well situated to make those decisions. And we do see that from time to time in California, that diversion is done by people who, quite honestly, are looking at it only from the perspective of the defendant, and they're not considering victims or the community concerns at all. So Long Beach, by the way, historically has been very active in prosecutor-led diversion. I'll mention just 2 cases before we talk about the main topic today, which is mental health diversion. But 20 years ago, the Long Beach City Prosecutor's Office started a community service worker, or CSW, diversion program as an alternative to the traditional Caltrans, which is really a forced labor or court-ordered program. CSW workers in Long Beach got to choose the work that they do. It could be tree plantings. They can assist with beach cleanups. They help with wetlands preservation, graffiti removal, park maintenance. They also help with some of our community gardens. This large photo is from the Martin Luther King Community Garden in Central Long Beach, where some of the elderly gardeners don't have the ability to take care of their gardens fully. So once a month, our CSW workers will go and help them. They help with neighborhood special cleanups. So really, it looks more like you're a volunteer in the neighborhood than someone who puts on an orange vest and has to clean up trash on the side of a freeway. And you get to choose that work yourself. In the last 4 years, we've had over 4,000 people participate in CSW. There have been over 650 different volunteer opportunities. We call them volunteer opportunities, but they're really trying to, get hours to complete their service. And about 136,000 hours of work has been completed over the last 4 years. 2/3 or 65% of CSW is done pre-filing. So no cases ever filed in court. The other 1/3, of course, is really an alternative to paying a fine in court or maybe even spending a short period of time in jail or doing Caltrans work. It's an alternative to that. It was named the best program in America by Neighborhoods USA in 2016. And for the sake of time, I'm just going to tell you there's a video on our website. You can go to our website and get more information if you want to about that. In addition to CSW, another prosecutor-led diversion program is something we started a few years ago called Promising Adults Tomorrow's Hope, or the PATH program. It's an education and jobs-based court diversion program for 18 to 24-year-olds. So these are our youthful offenders. They're all adults. In California, at the age of 18, on your 18th birthday, you are no longer a juvenile. You are now an adult and subject to the adult system. In other states, it may be 16 or 17, but in California, it's 18. But you know what? Our youthful offenders, our 18 to 24-year-olds, we probably shouldn't treat them the same way that we treat someone who is 30 or 40. Their brains are still developing, and they are susceptible to diversion programs and alternative programming. So we created a program with our local workforce investment network, which is funded by the U.S. Department of Labor. All of you, every prosecutor has a local workforce investment network funded by the Department of Labor. Finding it might take you a little while, but we found ours. And we created this program by sending cases to them to allow them to do one-on-one, job, we call it concierge job services. And they help people who are 18 to 24 years old get job training, get back into school if they've dropped out of school. It helps get them certificates. 93% of our cases were handled pre-filing. So only 7% of our PATH cases were referred after the case was filed. 93% avoided the case ever being filed in court. This number is actually old. So by now we have probably had over 700 people who've received education or jobs assistance. This was cited by the National Institute of Justice as a developmentally appropriate criminal justice response to justice-involved young adults, because we are treating young adults differently than others, because the age of 18, nothing has changed between your 18th birthday and when you're 17 years and 11 months, but our legal system certainly treats them differently. So we decided to treat them differently, and this has been a program that's gotten a lot of success. Both of those were prosecutor-led diversion programs. So using that experience, we looked at a problem that we saw was mounting in California. Probably about 5 years ago, we noticed a dramatic uptick in homelessness. Now, your community may not have the same type of trend that we have here, but homelessness is a very, very serious trend in California and in Southern California. In Long Beach, in our last day that we did a census, it was around January of 2020, we had over 2,000 persons experience homelessness. That was a 24% jump from the previous year, just in 1 year, 24% increase. Long Beach is a fair weather community. We have great weather here, great place to be homeless because you can live outdoors and really not be exposed to elements too much. As a result, Long Beach, according to the Department of what's HUD, Housing and Urban Development, they said that Long Beach had the second highest percentage of persons experiencing homelessness who are completely unsheltered. They live under bridges, they live by rivers, they live by freeways. They don't have any shelter other than maybe a tent. So that's a big problem. Drugs are prevalent in encampments, and many people who are in encampments also suffer from very serious mental illnesses. That was alarming to us. We saw that trend a few years ago, but what was really alarming was what we saw projections to be in the next 4 years. The Economic Roundtable is a nonprofit here in California, and they projected that over the next 4 years, persons experiencing homelessness will increase about 49% across the United States, about 68% just in California, and 86% in Los Angeles County, where Long Beach is located. We're the second largest city in LA County after the city of Los Angeles. So we really see this as a community problem. It's not a prosecutor problem. You know, it's not within our job description to focus on the homeless problem in Long Beach. But again, we're uniquely situated as prosecutors so that when people who intersect with the criminal justice system, who are homeless, mentally ill, and or addicted to drugs, we're really uniquely situated to try to help them. So seeing that trend, we started a program, a prosecutor-led diversion program that we called Priority Access Diversion, or PAD. And I'm going to introduce Laura Reimer in a moment so she can talk about PAD, but PAD has changed a little bit over the last few years. COVID, of course, has changed everything. And a lot of the programs that we used to refer to are community-based programs that had to reduce the bed space they had during COVID. So the number of capacity that we had, the number of beds we had, dramatically dropped, and we had to make do with the resources that we had. But I'm going to allow Laura Reimer, who handles the PAD program on a day-to-day basis, to describe how it works here in Long Beach. And then if we do have a few minutes to answer any questions, hopefully she'll answer it or I can answer it. Laura, are you there?
I'm here.
Great.
Hear
You
me?
want to take over the discussion about PAD now?
Sure. Hi, everyone. Thank you for having us. So as Doug mentioned, several years ago, we started a program when we realized that our traditional methods for dealing with certain categories of people were just not working. The revolving door in and out of county jail was clearly not helping the individual or our communities. So we got creative, or Doug, I should say, got creative. I am just he's the brains, I'm the brawn, I suppose you could say. So I'm running these programs in the courthouse. So PAD is sort of an umbrella designation for several different programs that we have. Some are pre-plea, some are post-plea, in which the person can end up with the dismissal of charges at the end of completion of substance abuse, mental health treatment, et cetera. And some are, they keep their conviction, but in lieu of significant amounts of county jail time that they are facing, they are sent to residential treatment facilities for substance abuse and or mental health, often co-occurring. One of our main partners is called the Los Angeles Centers for Alcohol and Drug Abuse. They have a person embedded in our courthouse. And when the public defender or myself sees a case that we think has issues that could be diverted through the PAD program, Amber will screen them. And if she finds that they are a good fit, they can actually pick them up directly from jail and take them to a residential treatment facility. And then they come back for usually a year of progress reports with the court. successful completion, they will often get their cases dismissed in the end. We have clinicians from the LA County Mental Health Department also embedded in the courthouse, and she can link people that are missing the substance abuse element and send them straight to mental health facilities as well. When the program first started, it's gotten much bigger, but in the beginning, there were 48 cases of people that entered into the PAD program, and 83% of them were still in a residential inpatient facility 60 days later. So it's had great success and has only continued to get better since then. Long Beach has also added a booking clinician. We have an actual mental health person that's in our jail that will screen people when they come into booking. And the way it works, she will call me or shoot me an email in the morning and say, hey, this person I think would be great for the PAD program. Yes, it's Medicaid. I saw a question come up. And I can answer more questions at the end. So our booking clinician will email me, and then I can screen the case on an individual case basis, make sure it is a case that complies with our categories of what is acceptable and what is not. And then I will write in the offer that goes to court, send this case to LA CADA or some other programs that I'll talk about in a minute, and we can get the case diverted that way. We now even have a social worker, an MSW on our staff in our office, which I think is fairly rare for a prosecutor's office to have a social worker on staff. And she has a lot of experience in our community with various programs. And so she works with me and the office in general in finding programs that already exist that we can link people to as well. And we recently started another program that falls under the PAD umbrella called Rapid Diversion Program. We call RDP for short. It is a program for mental health and or substance abuse that would normally fall into diversion via a new statutory mental health motion that defense can file. It's a lengthy motion. There's a special courtroom for it, and it still exists. But we have come up with a collaboration to avoid the lengthy motion process. If the prosecutor and the public defender agree to the mental health diversion, then it's a much quicker process. So there are 2 linkage people at the courthouse that meet with defendants and find them almost immediate shelter if they don't have it, and link them to mental health and substance abuse treatment. And those are pre-plea. All of those cases, as long as they complete a year-long process of progress reports and treatment, they never have to plea and the case will be dismissed. And then another newer program that we have started in Long Beach that's unique to our office is a homeless court. So we have actually created an off-site courtroom at our local multi-service center, which is a place that people experiencing homelessness, many of which have mental health issues, are already familiar with. We have taken one of their classrooms, and we have a judge that appears via WebEx. Myself and a public defender are there, and people can sign up through a portal. If you want to just check it out of curiosity, it's on our website. And they come in, they're usually brought in by either the police department, who are familiar with them, or officers that work out in the field in the encampments, or their case managers and social workers will bring them in. And we have a variety of wraparound services present during the courtroom so that they can come in and deal with cases in a less intimidating environment. They are linked immediately to substance abuse, case managers, job counseling. There's a warrant detail from the police department that can pull bench warrants out of the system. Various other people. They're all there. So these people don't have to actually leave the courthouse and go find these services on their own. We have everybody in the same room at the same time. So in the last couple of months since we started, we've had 40 clients come through that actually had cases on calendar. We've dealt with 89 cases that are misdemeanors, 15 infractions, and that's not including dozens of people that have come just straight through to record clearing for expungement and other type of record clearing motions. So that's been really successful. And we have several people that have gone from being in the encampments, just talking to themselves as they come in, and various other things that you might see that are now in permanent housing. So it's really neat to see the progression of people that have come through, not only the homeless court, but all of the other programs, excuse me, not problems. And let's see, I think that's all I have unless anybody has any, one other thing we have that's really cool is our office was given a grant for a program that's going to be called Guides. It's an actual app that all of our field officers, our police department, will have out in the field. And when they enter in someone's name into the app, they will actually be able to directly connect them to services straight from the field. So that'll be a really helpful program that hopefully will lower our amount of people that have to come through booking to get connected to services. I think that's all I have. Doug, did I miss anything?
I don't think you missed anything. And out of consideration of the time crunch that we're in, this page has the direct email and phone number for myself and for Deputy City Prosecutor Reimer. I would just encourage anyone that has any questions about any of these programs, feel free to reach out to us. We're happy to share with you our journey so that you can learn from the mistakes we made along the way. And I would describe our programs as really programs that resulted from our wanting to do diversion and then figuring out how to get it done without a lot of resources. Because the city of Long Beach is a high need city without a lot of resources. So we had to figure out how to accomplish these goals that I mentioned, the goals of reducing court congestion, improving the outcome for defendants and other individuals, and keeping the community safe. But we did it without a lot of funding in order to accomplish that. By the way, now funding is coming. So in Los Angeles County, they've approved a few measures. And so the county is coming up with programs that cities like Long Beach can connect people to. So we are going to see a lot more resources coming, but we had to create these programs with zero resources from the inception. So thank you very much.
Thank you both so much, and for your willingness to take questions in the chat and by email. We're going to move along to our next presentation, which is from Amberly Prihodka, the Director of Clinical and Professional Services at the Institute for Justice Research and Development. And Amberly will be talking about stress and resiliency and secondary trauma training. Thank you so much for being with us and for your patience.
Hello, good afternoon. I'm going to share my screen now. Great job, Vincent, for getting all of these really tough last names right, by the way. My name is Amberly Prihodka. As he said, I'm the Director of Clinical and Professional Services for the Institute for Justice Research and Development. I'm a licensed clinical social worker, so I'm a therapist and I'm a mental health professional. And at IJRD, our mission is really to use science to reduce unnecessary reliance on the criminal justice system. And we do that by identifying solutions through research and then rapidly getting that research into the hands of people who can actually use it, like you all. So part of my role is being able to do trainings and consultations and working with individuals to talk about and teach and help implement what we're learning as we're learning it. And so today you all have talked a lot about mental health and others and how to be responsive to that and how to best serve those populations. And it would be really sad if we went through the day and didn't talk at all about your own mental health and your own challenges that you're experiencing. Because the truth of it is, working in criminal justice is really tough. And you all are you're coming up against a lot of really tough things. And generally we like to talk about this idea of self-care, and such a lovely, wonderful idea. And I've really been on a crusade almost for the last few years to change the way that we talk about mental health and self-care for ourselves, for those of us who are working in the criminal justice system. Typically, we go to these trainings, if there is a training, right? And there's a little piece about mental health and self-care, and it goes something like this. We say, wow, your jobs are really hard. And here's the impact it's going to make on you. You're probably going to have strained relationships. You might be more angry than the average person. You might even develop illnesses and be at more risk to die early. And by the way, be sure at the end of the day to take a nice walk and drink some water, and don't forget to take a bubble bath, right? That's kind of the idea generally that we think about when we hear the word self-care. And, I am a trauma therapist, and I think about it from that experience, right? And from that lens. And if I were to, and I work with individuals who experience secondary trauma, which is coming up against trauma, hearing about trauma and having that impact you, and who experience trauma in their jobs every day. And if I said in therapy, oh, here's all the terrible ways that these things are affecting you, be sure and take a walk after you get done with this, people would think that that was crazy and that was silly, because that doesn't work, right? And the bottom line is, the things that you're going through, whether we call it trauma or not, there's some traumatic things that are happening. We can call it really stressful and overwhelming experiences. And so I'm going to go through this. I typically ask for a lot of interaction in the chat, but for the sake of time, I'm not going to do that. There's this sort of normal stress, that comes along with your jobs every single day, way before we've experienced a pandemic and all of these things, right? Like, you hear stories about challenges, you hear stories about people who are suffering, you see people who are suffering in tremendous ways. You are working with families who are saying, please help my loved one who's suffering. There's so many things. Maybe there are changes, right? There's changes in leadership. There's changes that you have to deal with every day. That's a normal work stress, right? Normal. There's policies that either you maybe fully agree or don't agree with, but you have to comply with them within your workplace. You have to look at how maybe somebody else, maybe you're working with family members and they're saying, we don't understand why you can't do this. That's sort of the normal stress, right? And I know these are a few examples. I know you all could give me many. And then introduce an actual global pandemic. And not only has that added tremendous personal stress to many, many people, that has added to, I've talked with people all around, that's added to the volume of your cases now. That's added to changes in the way that you work. That's added to maybe you're feeling okay, but you're seeing a colleague struggling and you don't know what to do. And so people are saying, what is wrong with me, right? They're feeling not normal. They're feeling really overwhelmed. And I just want to say first and foremost that it's normal not to feel normal in the way that you're going through your job right now. We are at a prime time for burnout, for overwhelm, because of all of these things that have piled on, and you've just been expected to continue to function and help others who are experiencing trauma, right? So all of that comes back to you. And when we don't sort of acknowledge that, I start to hear things like, what's wrong with me? Or maybe I'm thinking about changing careers. I'm thinking about all of these things because we don't understand that this is a perfectly normal response to what you're also going through. There are some better ways, right? So if you just think about the way that you're coping, a lot of people, it's ignoring it, right? This is just part of the job. This is what I signed up for. We just continue to move through it day in, day out until one day, we explode or whatever it might be. So think about how you're currently coping. I'm not going to ask you to share that. Some people right now we know are drinking more. Some people we know right now are eating more. People are doing what they can. And this happens anyway, right? When you're in these incredibly stressful jobs. However, it's even extra now. Perhaps you are shutting off from loved ones. You're isolating. Maybe your relationships are impacted. Or maybe people are going, no, I need to do this self-care thing. People told me I need to do it. So starting tomorrow, I'm going to work out 5 times a week, and I'm going to only drink water, and trying to make these big, huge shifts because they're trying to cope. And so what's important to remember is that making those big shifts, trying to do it all at once, is really challenging, and it doesn't often work. But we have to do something. And the first thing that we can do is simply just recognize that our responses to what's happening to our extremely stressful work environments are biology. And we can't ignore it away, and we can't do these things to just make it go away. However, what we can do is learning to understand these biological responses. And when we start to understand these biological responses in our own selves, this helps us to be able to proactively, in the moment, respond in ways that can lower stress. So things that we generally attribute to just a character trait. And this is also really helpful in understanding the individuals that we work with. So maybe, oh, this person's just really angry. This person's just really likes to isolate and shut off. Those are generally actual symptoms of the overwhelming work experiences and stressful work experiences or other experiences that we're going through. And so when we can acknowledge, when we can notice, this is a response, this isn't a character defect, this isn't because I can't handle my job, this is a perfectly normal biological response. We can acknowledge that, we can see that, and then we can start to, throughout our day, to incorporate things that can help us. And then that shifts us. So this idea of self-care is kind of reactive, right? You wait until the end of the day and then you do something. But there are techniques that can shift us from being reactive to being proactive. And I want you to go away with something small at least. So even just if you notice whatever it is in your own body, maybe your heart races, maybe you're a little short of breath, in those moments, that's a stress response, that's a trauma response. Even simply just taking a really deep, slow breath and letting it out is talking to the part of your brain that is sending that trauma response, and it can help you rebalance. And that's what it's all about. When we're thinking about biological responses to stress and trauma, we want to rebalance. I'm gonna go a little fast, I know. There's also a term, we talk so much about secondary trauma. We talk so much about vicarious trauma and how even just hearing the things that you hear from others can actually impact you and can actually cause trauma responses in you. But there is something called vicarious resilience. And this is the idea that just like the idea of being in close contact with others who are experiencing trauma can create trauma responses in you, being in close contact to those who are experiencing trauma and demonstrating resilience, which all of the people that we're working with are, can actually create more resilience in you. And having that in our minds, that actually starts to change our brain and helps us to be a little more hopeful. There are things that we can do to actively cultivate this vicarious resilience. So we know it's possible, and then we can actively cultivate that. Just like we can recognize our trauma symptoms, and there are things that we can actively do to balance our system. This helps as well. And so what I want to leave you with is a little exercise that you can do. You can, and I would recommend doing this weekly. This is about kind of an easy way to be mindful. But what you're doing is you're exercising your resilience muscle. And you just think about, and you can go back, you don't have to do it now. You do have the PowerPoint up online. some positive ways. So rather than only focusing on the challenges, right? Focusing on the positive ways you've been changed as a result of your job. And then this one is really wonderful too. Think of a really tough case. What are some qualities you saw demonstrated that you wanted to grow and cultivate in yourself? So maybe you saw someone you were working with, and there was this quality of never giving up or whatever it is. And you want to cultivate that in yourself. And just think about small things that you can do. So this is just a really tiny snippet. We could, and I think it's so important, and thank you all so much for what you do every day. It's so important to talk about your mental health and really shift from being reactive to being proactive. And so I gave you a little snippet of some things you can do. We do a lot of trainings to help with this. It's something I'm incredibly passionate about, so that you can really create your own well-being maintenance plan along the way, rather than just this idea of once you're kind of tipping over the edge to burnout, to react to it. And so thank you all for having me. I will look in the chat for questions, and I will also put my email in the chat. And my email is also on the PowerPoint that that is shared online. So I welcome any and all questions, and would love to talk to any of you more. Thank you.
Thank you so much, Amberly. And as Amberly said, please follow up in chat or by email with any other questions. The next person we have on our schedule is Julie Turnbull, our Chief of Restorative Justice in Dallas County, Texas. And Julie, seeing that we were so crunched for time, so kindly offered to just leave your PowerPoint and take questions by email. But rather than doing that, maybe if you wouldn't mind just introducing yourself and giving a brief overview, 5 to 7 minutes or something like that, that would be super helpful in getting us back on track. Thank you.
Okay, sure, I can do that. I'm from Texas, so I can talk real fast. So I will do something in about 5 to 6 minutes. I won't even go through my PowerPoint, really. It is online and you can see it. But I'm Julie Turnbull, I'm from Dallas. And our district attorneys, we have a restorative justice division. And one thing that I think has been interesting, when I visit other jurisdictions, is how are you set up even on an org chart, to do restorative justice or to do diversion. So I just wanted to touch on the fact that, we have a division that has been created that handles all of the specialty courts. It handles our diversion programs, and it also handles our mental health division. And so we have 9 prosecutors and an investigator. We have a program clinician, so that we do have a licensed professional counselor to give all the attorneys advice on these types of things, as well as support staff and case managers. But we also use a lot of volunteer prosecutors, and I always like to kind of point that out on calls like this, because sometimes funding can be an issue. So we actually use chiefs of divisions and chiefs of courts at our office, and they'll volunteer for different diversion programs and to do staffings for some of the specialty courts. I was going to touch on we are also opening a deflection center here in Dallas, hopefully, fingers crossed, in January of 2022. We copied everything from Michelle that you heard from about Harris County. So kudos to her. She took every email and every phone call and has met with us in person. And we have really bugged her to death. And we have modeled our program very similar to hers. So really no need for me to touch on that because she explained that so well. But one thing about these calls, when we have all the prosecutors together, it's great to see how we can learn from each other. So I would love to pay it forward. So I know there's been some discussion of other jurisdictions and even smaller jurisdictions wanting to start deflection type programs where law enforcement is dropping off individuals charged with low-level criminal trespass cases instead of dropping them at jail. And so we, like I said, have something very similar to what Michelle explained. And if anyone wants to reach out, I'm happy to pay it forward and let you know about the trials and the tribulations that we have had trying to get this started. We do have a very strong mental health division at our office. Our prosecutors in that division handle anything from 250 to 300 cases at any given time. But we are very focused on trying to offer pretrial intervention agreements as much as we possibly can for those that have mental health issues. And so we have a referral process for that, so that our mental health division can work with those defendants. One thing that our office did get, our elected DA, John Crusoe, was able to get case managers from our local mental health authority, as well as one of our Dallas County mental health agencies, to provide case managers to help our prosecutors full time, so that our prosecutors are not the case managers, but they can work on the legal side of it, but then they can allow the case managers to come up with the individual case plans and so forth. So I'm real proud of our mental health division. And then the one thing I really want to touch on is that we are starting a new pretrial diversion process in Dallas. Our office got several grants so that we are able to provide clinical assessors for our criminal justice department. We were able to hire them from our office, but we placed them in a neutral department in the county. But they are going to be doing pretrial assessments. I know there was some talk about the ORAS. We will be doing the TRAS, which is the ORAS, but has been validated for Texas. And there's various screeners at the end of the TRAS to determine if there's substance use issues or further mental health issues. So we've been able to provide those clinical assessments and to catch people at bookend, and as well as receive referrals from defense counsel or prosecutors, or even the defendant themselves. We're handing out a business card when anyone books out at the Dallas County Jail. They'll get a card that says, hey, is this the first time you've been arrested for a felony? You may be eligible for diversion. Actually, we say you may be eligible to get your case dismissed, because that gets their attention and that way they call. And then we can hopefully get with their attorney and get them set up for an assessment. Assessment is key. And so we want to make sure that if we identify their risk needs, then we then will, from our office standpoint, pretrial, funnel them into the appropriate way to handle them, whether that's a specialty court, if it's a high risk, high need offender. Obviously, if it's a low risk, low need offender, we do not want to put someone like that in a specialty court. So we will put them on a pretrial intervention agreement, kind of like a conditional dismissal. Or if the mental health issues are such, we'll forward them onto our mental health division to work with them. We're also doing that for prostitution cases, regardless of whether or not it's a first-time offender or not. We have a human trafficking assessor that will assess as they're coming through the jail, and we will offer that automatically, a pretrial intervention agreement to get them connected to services at the misdemeanor level with a local nonprofit, or at the felony level, get them into the specialty court that we have established for those prostitution offenses. And last, we just recently I was going to talk a little bit about some of the tools we use, and we obviously, the assessment is a huge tool, but we also got some software that we just purchased. We were working on spreadsheets. I'm sure there's other jurisdictions that maybe that we're doing things that way, but it's so key to make sure that you have the software available to track everything that you're doing pre-trial diversion, so that you can have the researchers come in and take a look at your program, make sure it's effective, figure out where you can tweak to make it better. So in a nutshell, that was kind of what the PowerPoint was about.
That's great. Well, thank you so much, Julie. And we can actually, let me just confirm, we may have caught up with ourselves to some extent, because I think that, let me just confirm to see if some of our expected next speakers are with us. I know that DA Beth McCann from Denver was running a little bit late. Emma, do you see her on just yet?
Let me take a look.
I don't think so.
Yeah, I'm not seeing.
And then Judge Blanco, I don't yet see either, but please let me know, Judge, if you're on. So great. So Julie, if you wanted to take another moment or two to talk about the restorative justice tools, you can do that. And we can also just have questions for other speakers, but I see you're still there.
I'm still here. I know I went through really quick, so they may have more questions for other speakers, but I'm available if anyone has any questions.
Yeah, we can take a couple of minutes for questions if you like, and then I'm going to introduce Chief Brandt. Danielle Smith has put a question in the chat. What software do you use?
We are using the Tyler supervision software. So it's a case management software. We've altered it a little bit for our purposes here, and it does track everything from when we identify them at book-in all the way through whether or not the attorney does agree to have them be assessed. And then obviously once they are assessed, all of that is captured, all of their identifiers, and then they are funneled into, as I said, the different courts. We have several pretrial diversion courts, a youthful offender court, a drug court, mental health courts. We will funnel the high risk, high need offender into those. The low risk, low need offender, we will craft a particular pretrial intervention agreement that's specific for that defendant. We try to make them attainable, 3 to 6 months with just a few conditions. And that is all tracked through the software. And then again, if they're in the mental health division, they are tracking everything, all of the pretrial intervention conditions that they have with the case managers that help provide all the services for the mental health defendant. And that's all tracked. And then the cases are all dismissed at the end if they're successfully, if they successfully complete, and they are all eligible to immediately file for expunction with our office so that it really is off the record.
Great. Well, thank you so much. And thank you so much for speaking quickly. I appreciate it. So let me just introduce the folks who've joined us and will be part of this next section, which was intended to be a panel and a discussion. And just as we head into it, knowing that we're crunched for time, so we'll ask each of you to just sort of briefly describe your work. And we could probably take, 7 minutes each or something like that. If I'm doing my math right. And then a little time for discussion and questions and answers. That would be great. So let me first introduce Susan Blanco, who's the Chief Judge of the 8th Judicial District here in Colorado. Thank you so much for joining us, Judge Blanco. And then I'll introduce each of our other folks as well. Let me go ahead and introduce the other folks that I've included in the panel, and then Judge Blanco, you can begin. I'll also introduce Chief Rick Brandt, who's the Chief of the Evans Police Department here in Colorado, and Beth McCann, who's the Denver District Attorney. Thank you all for joining us today. So Judge Blanco, please begin.
Thank you. Thanks for inviting me. I'm excited to share with you some of the things that we're doing here in Northern Colorado. So sometimes I think that criminal justice and mental health, it's almost like the Matrix where somebody gave us the red pill and we don't get to see the augmented reality that the law solves all the problems and everything goes smoothly once somebody comes to court. And so when we were posed with this situation that many of you are in, where people are in line to go to the state hospital waiting for restoration efforts and the lines are exorbitantly long and there's not a lot that can be done, it was a very upsetting, very disappointing track, and COVID made it worse. So what we did is, for those that are getting a competency evaluation, competency has been raised in their criminal case, what we've done is we have created one docket on Tuesday afternoons that we call the competency docket. It's pre-plea normally, so it's not a specialty court, but the referral is made for that case, that individual, to come to this exclusive docket on Tuesday afternoons. And It has basically the same public defender handling the cases who has a background with mental health, has the same prosecutor who's also examining the cases, and it has myself as the primary judicial officer that is overseeing the cases. And along our side is some of the professionals in our community, ranging from our local mission, where we have 5 beds for people who we can use for folks that we want to do outpatient restoration with, our local mental health, our jail, and our Bridges program, which is our liaison that really kind of is that warm handoff person who's following the individual through the community. And you name it, our ARC, our folks that work with ID and DD populations, traumatic brain injury. We're trying to include our VA. They're kind of on the periphery, but we have all these folks at the table. And then we also have our attorneys, county attorneys, and our local attorneys that do probate work and that do the civil mental health commitments. And so what happens with this large group of people is there's an exclusive core group like the DAPD, our local mental health, and the jail and Bridges that are meeting every single week on that docket. And then every other month we have a large expansive meeting with the larger stakeholders. And so what we found is there are 20 right ways of doing something when you have 20 judicial officers handling cases, and that this consistency of one judicial officer is really nice for the predictability of how things go when people come to court for the stakeholders. Having one DA and one defense attorney, and that same philosophy has been very helpful so that we're able to keep the momentum of the discussions and kind of go back to building a wheelhouse of how we want to handle matters. And what we've done is increase the efficiency of how cases are handled. We have the doctors that do outpatient evaluations in the hallway on Wednesdays. We can directly calendar with the doctors. We trigger discovery through the criminal justice system, through the court's judicial assistance, straight to the DA to get the information to the doctors faster. We are having discussions earlier on as a team. We're talking about what services can be wrapped around people. And then on Tuesday afternoons, I'm talking a mile a minute because I have 7 minutes, but on Tuesday afternoons, I speak slower and things are calm. And the people that are on that docket and their families have more time to ask questions, to process information, to better understand what's available in the community or how the case is going to go through the court system. And so we slow things down. We're talking about people more on an individual basis. So, you know, just anecdotally, we've had people who they are very low IQ. There's nothing the hospital can do for them. And so creating a different path for them to exit out of the criminal justice system has been fruitful. We have people with dementia. There's nothing the state hospital can do for them. So we are taking them out of the line to go to the state hospital and giving them local services that can wrap around them. And that individual basis and looking at people as a particular individual has been very fruitful. We have a lot more people on outpatient restoration, and I think we may be the only place in the state that has curbed the stats. We are not putting as many people in line, and we are starting to have more local control over how we're handling these cases. And outpatient restoration has been a more fruitful approach for us as a result of that. So we're helping create kind of a hub in this docket, and people are going to diversion, or they're having their cases dismissed if there's enough wraparound services and not a community safety issue at hand, or they're getting restored, or, you know, any kind of one of these ways to navigate through a system that is really not developed for folks that are in this position. And we're using the state hospital for what it's intended to be used for, not perfectly, but we're getting there, so that we're not sending people, you know, like low IQ, ID, DD folks, or people, dementia, and this kind of thing. We're not sending everyone to the hospital when there's no fruit to be gained there. And so we feel like this early intervention, this moving through the system has been very helpful. And the feedback that we've had from families, from the stakeholders, is a higher degree of appreciation for what the judicial branch is really doing and what the community is doing to try to support this population, particularly because it's sustainable when they're no longer in the criminal justice system. Gosh, I don't know, Vincent, does that feel like 7 minutes? Did I go 20? I don't know what I did, but I hope that was, I hope it was engaging.
Very much so. Thank you. And much more in the ballpark of 7 minutes than 20. Thank you so much. If you can stay with us a little bit. We may have some time for questions.
Be happy to.
Chief Brandt.
Well, good morning, Vincent. Thank you for having me. I guess it's afternoon for most of us, sorry. I'm going to try to share my screen here without blowing anything up. I'm not going to go through my entire slide deck. I'm just going to go to the last slide in the interest of time. So I want to talk to you all and describe a bit of our behavioral health co-responder program that we have in the city of Evans. Originally, I had a sort of the path to this program and how we arrived here starting in 2016. But again, in the interest of time, I think I'll just cut to the chase. So the long and short of it is this. Next week, I will celebrate my 40th year in law enforcement. So I've been doing this for a minute. And as I aged and maybe gained a little bit of wisdom, I became increasingly frustrated with my role as a police officer in addressing, number one, being virtually compelled to address a myriad of social ills that we're not equipped to address, and sort of the ineffectiveness of our current judicial system in terms of incarceration, stigmatization, all of these things that go with going through our criminal justice system. And what I've come to learn is if all of that stuff worked, we wouldn't be dealing with what we're dealing with today. So I became very interested in looking at some alternative ways to maybe work with stakeholders and see if we as police start being part of a larger and broader solution, rather than sort of that standalone gatekeeper of just pushing people into a criminal justice system that largely is ineffective in treating things like substance abuse and behavioral health and all of those related things, and homelessness. So in Evans, we like everybody else, we were experiencing an increase in homelessness. We do have a cold weather shelter in Evans. We also have a housing navigation center in Evans. It's kind of like the old adage, if you build it, they will come. And we seem to have really seen an increase in our homelessness population here. And like other cities across the country, we saw a spike in drug use, specifically opioid use. So my pathway to this co-responder program started with Narcan and introducing Narcan first in Weld County and then throughout the state of Colorado. Me and some other stakeholders, we have trained over 200 police departments in the use and carrying of Narcan. And I'm still a point of contact for Colorado law enforcement to obtain Narcan through a grant at CDPHE. So when we started the Narcan program, the whole concept of our primary mandate is the preservation of human life. It was not a hard sell for police departments to embrace this concept of saving lives. And an early lesson that we got when we started doing these reversals, deploying the Narcan and reversing people and saving their lives, they would be transported to a hospital. And, just being a simple policeman, I assumed that while they're in the emergency room or emergency department, they would be connected with services to help them deal with whatever it is they're dealing with. Well, what I learned is that it took about 45 days for the ED to notify our local behavioral health center, which was North Range Behavioral Health. And within that 45-day window, we might reverse another 2 or 3 times more overdoses on them. They would be out reoffending, committing crimes, taking their drugs, and overdosing again. So I met with directors from North Range Behavioral Health and asked how we could do this warm handoff that we've heard throughout the morning. How do I get these people immediately connected with the services that are going to make a difference for them? And North Range told us, well, you can call us directly. So I had my officers, when they did a reversal, they could just call North Range directly, and they would send one of their staff over to the hospital and start offering services. So that worked okay. So as we were continuing on this program, we elevated our relationship with North Range, meaning the director and I, her name is Kim Collins. We had a discussion about, well, what if we embed one of your clinicians in my agency and they can go out on these calls with us? So they gave us one of their master's level behavioral health clinicians for 20 hours a week. So he was embedded with our agency, and we were using him sparsely because it was a new program. And this was in about 2016, maybe. And we were doing that for a little while, working okay. Well, then in 2018, in April, we had a grant opportunity in Colorado for 8 sites in the state to develop a co-responder program. So I had applied for that grant because we'd already had the relationship with North Range Behavioral Health, was awarded the grant. And with that grant, we get about $360,000 a year. And the way that works is now we have 5 full-time clinicians embedded between the Evans Police Department and the Greeley Police Department. So I invited my neighbor to the north, Greeley PD, to partake in this endeavor to see if we could get co-responders in the street. So it's been, we've been working this program now. We're in our 3rd year, and it has grown. The city of Evans, we don't see a penny of the grant money that comes through. We're just sort of the pass-through for North Range. So these clinicians that are embedded with our agencies are full-time employees of North Range Behavioral Health, who, by the way, have been just a magnificent partner in this. And with that money, we purchase things like transport vans for the clinicians so they can do their own transports. They have police radios. They have the ability to self-deploy. So if they're sitting in the station house and they hear a call come out that might involve some sort of behavioral health issue, substance abuse, suicidal ideations, whatever it may be, they can get on the radio and tell the officer, hey, I'm en route, I'll stage nearby, let me know when you need me. Officers can call them to a scene. And a couple things happen when the clinicians show up. Number one, it's been my experience that when you mix some sort of behavioral health crisis with a badge and a gun, things tend to escalate. So these folks help us de-escalate these situations. They have a much different approach to dealing with these individuals than police do. We're just not trained to do it, right? So we've seen the de-escalation. Another thing we've seen is time savings for police officers. So whereas an officer might respond on a call prior to this co-responder program and deal with individuals that might be 2, 3, 4 hours trying to get civil commitments on an M1 hold into an emergency room, which really doesn't do much good. Now the officer can make sure the scene is safe, have a conversation with the co-responder. If the co-responder says, yeah, get out of here, I got this, my officer's back in service doing what we should be doing, dealing with crime and disorder, and let the clinician start working with their client. So we've seen, I guess, a savings in that regard, and trying to focus our police officers on, really what I think they should be focusing on. And when people talk about this defund the police, that's how I envision it. Is we're not defunding the police, we're pushing resources out in the field that are needed that we can't do, and let's give it to people who know what they're doing. So as of, I think it was October of this year, the calls for service that the co-responders have been handling have been growing continuously, right, throughout COVID. We heard it with other presenters, mental health issues, behavioral health issues, substance abuse issues. So I think in October, they responded to 140 calls for service for police officers in Evans and Greeley. That's up from about 10 when we first started the program. I'm trying to get officers to buy into this and use it. And the next iteration, I guess, of all of this, it's highly successful. Another, I guess, outcome of this was agencies around us are asking, hey, can you send your co-responder over to help us on this call? So Greeley and Evans, we're sending officers, 20, 30, 40 miles away to other cities because they don't have co-responder programs in place, and we're offering help there. So the nice thing about North Range is they're a very large behavioral health center. They have over 500 employees, I believe. They have a broad range of services, and they're very committed to us. So we've had a lot of success in getting people plugged into these services. What we've expanded to just last year was partnering with the cold weather shelter and the Housing Navigation Center. So when we go out and we deal with my officers, get a call for somebody that's experiencing homelessness, who's maybe having a behavioral health crisis in the middle of an intersection, we can send the officer, we can send a behavioral health clinician, and we can send people from the Housing Navigation Center. And it's not quite a hub and spoke model. We don't have all the stakeholders at the table to address all of the needs. But that's sort of the next step is what we're hoping for, is to build this much broader, I think, like Judge Blanco was describing, a much broader wraparound set of services that we can bring to bear in Weld County. So from my experience, this is the future of law enforcement. It's been highly successful for us. And if there's any questions at the end of this thing, I'll be happy to answer them. Thank you for having me.
Thank you so much, Chief. The future of law enforcement, it's great to hear that. Very much in line with our Cure Not Cuffs campaign. Please do stick around if you can, and let's next go to DA McCann. Thank you, Beth, for joining us.
There we go. Oh, thank you for having me, Vincent, and thanks to Judge Blanco and the Chief talking about what they're doing. Both of those sound incredibly impressive and successful efforts to address some of the mental health issues. And I'm sorry I was not able to join you earlier due to other commitments, but I thought that I would talk a little bit about the diversion and restorative justice programs that we have in Denver. And also, I think wanted to focus a little bit on the community outreach that we do through those programs. So I think that Emma put my PowerPoint in. Yes, thank you.
Okay. Sorry about that.
And I'll try to go through this very quickly too. I realize we don't have a lot of time. So you can go to the next, or I don't know if I can control it, but so you probably have talked about this a little bit. You can go ahead and go to the next one. So, well, go back a minute. So we consider diversion intervention approaches that redirect participants away from the formal process, but still hold them accountable. So we try to get them out of the system as early as possible and help them make better choices in their lives and have a better opportunity to stay out of the system in the future. Okay, next one. Okay, so what we use for our youth diversion program is called the YASI, which is a screening instrument for juveniles. And the things that are listed there are the things that are evaluated. So family, substance abuse, school, community and peers, and violence and aggression. And if you hit the next one, it'll show how they kind of score it a little bit. So if someone, depending on how they, what their needs are, if they have family needs or school needs, violence and aggression, those are the focus, what our team will then focus on for them. And then the next slide is the SPIN risk assessment, which is what we use for young adults. And actually, we have altered this a little bit, but essentially it's kind of the same idea that we do a screening with each individual to try to design a plan for them that will meet whatever needs they have and help, again, redirect them from the criminal justice system. So you can go ahead. You can go ahead. And this is just kind of our process of how we go through this. So in both situations, well, with the juveniles, we have our juvenile staff look at the case, and then the DA actually makes an offer to go to diversion. There's an intake process. We do require that the juvenile sign a statement of responsibility, so they have to admit that what they did. And ultimately, the case is dismissed if the juvenile successfully completes diversion. The adult process is a little bit different. We didn't have adult diversion when I started, so I wanted to do a pre-file program. So we started a pre-file, so the case is not actually filed while the person is on diversion. And so the goal was so they didn't end up with a record if they successfully complete. We also make sure that when we review those, there is probable cause for the case to be filed. So if it's a case that we wouldn't have filed, then we're not going to make someone go through diversion. And then it's kind of a similar process. So the client starts the program and they get referred. We do use a lot of community resources for our diversion program. And each diversion person has a case manager, if you will, who helps identify their goals and their needs and put them into an appropriate program. Okay. So these are some of the programs that we run in our diversion programs. So we do cognitive behavioral health groups. We also can refer for substance abuse treatment, mental health treatment. We help with GED and testing support. We also partner with local trades organizations to place juveniles, particularly in apprentice programs for things like welding, things of that nature, where they can actually gain some skills. We also have a restitution program where they are required to earn money to pay back restitution, and we do help them through some programs where they get paid. We do have restorative justice in our juvenile program and in our adult program. Heat for Youth is a new program we're working with in Montbello, which is really work targeting kids who have the potential to be violent. It's a fairly new program, and we're pretty happy with the results so far. The staff does a strengths finders assessment for each person to see what their strengths are. And then we also try to refer them out for aftercare and for mentoring if necessary, or if it would be appropriate. Okay. So our restitution programs are things like our Walk Like Mad. We work with Parks and Rec, the food bank. Brush Off is a program that we work with outside of the office. All of these are community partnerships. So for example, with the Mad Walk, it's juvenile and adult. They go out and they set up everything for the Mad Walk, and then they do all the cleanup afterward. And it's similar with these other agencies. They work with the agency and they do get paid to do most of these. So it's a way for them to learn some skills and also to feel, like they're accomplishing something, and to allow them to pay off restitution or just to make a little money. And the urban farm is kind of a fun one, because the urban farm has goats and chickens and things like that, and they help with the animals and help with some of the farming that goes on. Okay. And this is an example of one of our restitution programs. This is an art program, and so the juveniles create and then market various arts and crafts kinds of products. I actually have some little holders for plants that they made, ceramic, and you can see there they do picture frames and various kinds of arts and crafts, and then they will go to fairs and sell their wares. Again, it helps them earn money to pay back their restitution. Okay, and we're pretty happy about this. So last year we collected $44,984 in restitution through both of the programs. So we are, holding them accountable and also restoring victims for what they've lost because of the activities of these young people and adults. Okay. So when I started, we also didn't have a restorative justice program, and probably most of you have heard of restorative justice, but it's essentially a program where the idea is ultimately to have the victim and the defendant actually meet in a circle environment, similar to like a peacemaking circle with the Native Americans, and they discuss what happened and the impact it had on the victim and his or her family, as well as what motivated the defendant. And they can be very, very powerful. We have facilitators who run the programs and are trained, and we have community members who participate. We usually try to have 2 in each circle who participate to help work through the issues. And we do try to pay the community members a small stipend, because we want to make sure that we are valuing them and not just sort of taking advantage of their interest in social justice. So you can go to the next one. So we're also pretty proud of our responses here. You can go to the next one, it'll put the figures in. So last year we had 84 successfully complete our juvenile program and 74 complete our adult program. So it's in relation to the number of cases we file, it's not huge, but the impact that it has on these individuals is enormous because they don't end up with a criminal record, because we do seal or expunge the juvenile records. We have the courts expunge those records and we can seal the diversion records, adults. So, okay, next one. So again, I just wanted to emphasize that we try to work with our community because I think it's really important for community members to know the kind of work that law enforcement does and that the DA's offices do, and partnering with them is very important. With our adult restorative justice program, we partner with an outside nonprofit called the Conflict Center, which does organize and do the circles and does the preparation with the defendant and the victim, so that they don't have to come downtown to the DA's office or go to a police department. They go to a community-based nonprofit, which I think is also really helpful to get them out of the criminal justice system. Okay, next one. So I won't go through all these, but these are some of our community partners that we use with in addition to the diversion, but also our adult diversion has branched out to encompass some of these community partners that are generally nonprofits that work with people who are in the midst of substance abuse or mental health or having problems with school or work, and that's why they end up getting into the criminal behavior. Okay, next one. So the restorative justice, and I'm almost finished. So just for people that are interested, these are the kinds of cases that we will take in restorative justice. We started with misdemeanors because we wanted to get the buy-in at a lower level, get the buy-in from our victim advocates and from our DAs, and also from the police department. And so now we've expanded into some felonies. And so you'll see some of those in here as well. And they generally have been successful. So the next slide. So year to date, we've had 114 referred. We had 6 that withdrew. You can keep going. Only 2 were unsuccessfully terminated, and then we had 79 successful completions. So, and then we watch our demographics very carefully to make sure that people of color are being offered these programs in a similar fashion. And making sure that our data is consistent with representation in the population. So you can see that we do have a pretty good reflection of the general population in Denver. It is more male than female, but we do have a lot of females. And our biggest age groups are that younger, 25 to about 40 age group. Okay, next one. And that's it. So thank you. I think I made it. So there's still a few minutes for questions if anyone has any.
Thank you so much. And yes, indeed, we do have a few minutes for questions, and I'll open it up to anybody. We've got a question in the chat from Vanessa Helms. Vanessa, you want to go ahead and speak up, or do you want me to?
Sure, sorry about that. Yeah, I was just curious, how many restorative justice cases do you have? I saw you had 114. Was that in 1 year? I'm just curious about in a year.
Yeah, that was year to date this year. Those are the people that are referred, and they don't necessarily all make it through successfully, but our numbers have picked up considerably over the last 2 years. Like I said, we started with misdemeanors, and we were only taking, I think, 6 cases a month. And then we got some additional funding and we went up to 8 cases a month. So now we're at 10 cases a month, and we're trying to keep at that level, depending on the funding that we can get. And we'd like to do more, but we do pay the Conflict Center through our budget and also through grants. We do pay them to handle the circles.
Thank you so much.
And we'll welcome any questions for DA McCann or Judge Blanco or Chief Brandt. And if not, what I would ask, maybe each of you could say a thing or two about is what you could advise with regard to developing public support for these kinds of diversion efforts. Any tips or guidance about that?
Well, I'll jump in just because we started a couple of these programs new in my administration, and at least in the community of Denver, I think the community was a little more welcoming than people in the office, to be frank, because there was skepticism about whether we should refer people to these kinds of programs instead of going through the system. But now I think people have seen that it is successful and are supportive. And we talk about it a lot when we go out to community meetings. We talk a lot about our alternative programs. And I think that helps a lot with community support. Just the more you can get the press to cover these kinds of things instead of always covering the violent crime, the success stories can be very persuasive.
And have you been successful in building that support in the office too?
Yes, I do think strategically we made a good decision to start with the lower level cases and build some support in the misdemeanor realm. And then one of the unintended consequences, which I didn't actually really realize until we had started it, was that those county court deputies move up into felonies as people leave the office. And so as they got used to, it was just part of what they did, was to analyze cases for restorative justice. So as they've moved into the felony courts, they're already on and used to it and on board. I think the victim advocates, they were a little bit of a harder sell because they work directly with victims, and we see the program as empowering victims because in our program, we will not do it unless the victim agrees. Some programs don't require victim agreement, but we do. And sometimes the victims don't want to participate, but they will say it's fine with them. And so I think our victim advocates have now kind of come along and can see it as a powerful thing for a victim's family or a victim to have a chance to tell the person that injured their property or injured them the impact that what they did had. And they can be extremely powerful, especially with the juveniles, I think.
And then there's another question in the chat from Doug. Do you want to speak up or do you want me to share your question?
My question was about the Strength Finders program. I think you said it's offered to juveniles. I'm familiar with the program, but I'm not sure if it's the same one. Can you tell us more about it?
Yeah, it's actually used for adults. And honestly, I don't know if they use it in the juvenile program. I should find out. But yeah, it's an assessment that you're probably familiar with, where it identifies strengths that individuals have. And then we have group discussions about how to use the strengths. And the individual case managers work with the individuals to design goals around where are their strengths. And so it's the idea is to lift up people. And being in the criminal system is such a humiliating and dehumanizing experience. So we're trying to let people know their value and how they can build on their strengths. So it's probably very similar to what you've been aware of.
Thank you. Judge Blanco, do you want to say something about developing public support?
Yeah, I would just say for sure. I just would encourage all of you not to be afraid to ask and let people just know in your communities what the need is and what the interest is. And so when we started this competency docket, we did not have $1. And we created an entire program that's the first of its kind in Colorado, and kind of the first of its kind in the nation, the way it's structured here. And it's been successful. And I think that community members that identify the need, everybody wants to, for the most part, help, but people just sometimes need that dialogue, the space to have the discussion. And so I don't think anyone should shy away from, in whatever project you're working on, reaching out to those stakeholders. They would not be in those nonprofits or engaged in that type of work if they didn't care about the population that you are trying to figure out how to serve differently in your own jurisdictions. And so I remember doing that as a guardian ad litem and a criminal defense attorney. Anyone who could not be restored, the judge would appoint me on their case. And I had no idea what the judge thought I was going to be able to do. But what I would do is just call everyone and bring a meeting together. And it just seemed to work when you would just ask and explain what the need is. So I would just keep encouraging you to think about that and reach out to folks.
Great, thank you. And Chief Brandt, did you want to make any remark about building public support for the diversion work?
Well, I think it's been a unique experience for me because of the demographics of the county I live in. It's a very, very conservative county. So, you know, to be able to, number one, leverage the relationship with North Range was invaluable. So that's one thing I talked to other chiefs about is you've got to start building those relationships with the other stakeholders to start. And as I said, we had the cold weather shelter, we had housing navigation. So we already had people at the table that I could connect with, and that was helpful. I did use two tactics in both this program. The co-responder program was a lot of media. I reached out to local media and even Denver media and invited them to come up and learn about the program and talk about it. And that was successful. And then with the Narcan, as we were rolling that out years ago, I actually used shaming for police chiefs. Basically told them either you put this out there, I'm going to tell the media you're not. And that seemed to help too. So fortunately at that time I was president of the Chiefs Association, so I had a little bit of pull. I don't have that anymore, but that did work initially. So once we got all that done, what's interesting, a lot of this is word of mouth in Evans. And people now, or my citizens, our residents, call into dispatch and they ask specifically for a co-responder. So that's been, that tells me we're having a lot of success in the community. So, and I also have a police advisory committee that I meet with monthly, and they were aware of all this from the inception, and that helped get the word out as well.
I have a question. Did you have resistance within your ranks, Chief?
Yes,
Yeah.
yes, that's a great question. Number one, with Narcan initially, there was some resistance. And then with the co-responder program, there was a lot of uncertainty, especially when you embed a clinician who has a little bit of a different mindset than a street cop.
Right.
It took a little time to work through the relationships, but having them fully embedded and working side by side with the officers has really made all the difference. And sort of like body-worn cameras, the officers find this program really indispensable.
Yeah, it's interesting. They said in Denver that the police were resistant to it initially, but now that they've gotten used to it, I think they actually do a little therapy for themselves with the clinicians when they're in the car, is what I've heard. So
might as well.
Yeah. But you'll hear them on the police radio calling for the star van or the clinician, which is great.
Yeah, Denver's program is very, very good.
Well, thank you so much. That's great to hear. So we're getting close to the end of our time, and I just have a couple of final things to mention. I want to thank again Emma and Adam for the support for this, and the David and Laura Mirage Foundation, the NFL Draftathon. I really want to thank all of you for being such great champions for health and safety. It really fills us with confidence and hope for our future as healthy, safe communities. It's fantastic work that you're all doing. We're going to send out a survey in a few days' time about this summit. We're also going to share follow-up notes and answers to questions that were unanswered. We'll continue to gather up any materials or PowerPoints to embed in the website page where Emma has built our agenda, and that will remain there as a resource, as will the recording of today's event, and you're welcome to share that with any and all. We are in early planning stages of a event focused on smaller communities, rural and frontier communities. So if any of you are interested in planning that with us, please shoot us an email and we'll get in touch. And then on that note of developing public support for these diversion efforts, if this is the kind of thing that if you are eager to do that kind of work, but short on administrative bandwidth, or would like some help in pulling stakeholders together, that's something that we can help do. So please don't hesitate to ask for that assistance. I think those were all of my final remarks. And if anybody else has any last things they would like to say, you're very welcome. Again, I apologize for the squeezed agenda. We packed too much in. It's a lesson always in figuring out how to do these virtual things. It seems like 4 hours is the maximum limit, short of illegal torture, to subject anybody to a Zoom meeting. It would be nice to be in person where we could be chatting over coffee and things around and between presentations. So hopefully we'll do that next time. If no further remarks or comments, with great appreciation for you all, thank you so much. We're ending you on time so that you can get back to your important work. Thanks again for joining us.
Thanks, everyone.